So, Elliot, you were talking about breakout sessions, right?
Yes, sir.
Yeah. Can you help us in understanding?
Ma'am, there are two sessions that I will share the case scenario with you and with myself. So, remaining there are two more. So, whom should I share with?
Elliot, you're not clear.
Am I clear now, ma'am?
Better.
So, there are two facilitators as of now, ma'am. So, you and Sukma sir. So, there are actually 4 case studies. So, should I share it with Jewel ma'am now, or how is it now?
No, Elliot, this is for Dr. Ashita's one, right?
Yes, ma'am.
So Ashita's, so I'm there, Ashita is there, Dr. Sukumar
Oh.
is there.
Okay. So Ashita ma'am will take one. Okay.
Yes, she will take one. And
So
I can see most probably Dr. Jamila will join in. She is actually attending another meeting. So she will join in at that. So if she joins in, she will take another session. If
Okay,
not,
so
if not, then I'll keep a watch over who is there, and then we can put one person.
so shall I split off that main thing and share it with third and fourth also with you, ma'am, now in WhatsApp?
Sure.
Okay.
Yeah, YouTube Live is already there. I just will share the link. You can just check and let me know if it has any. You're not muted, Dr. Rupa.
No, I'm not muted.
Yeah, now we can hear you. See, Chaco and Harold, can you check the YouTube link?
Yes, sir. It's coming.
Yeah, it's coming.
Yeah, I'll share the YouTube link in the WhatsApp.
Yeah, already people started entering, no? Dr. Rajesh, yes. Who is Rajesh? Resource person. FHC Tirupur.
Rajesh,
yes.
So I think only you are the host, so nobody else will be able to
Yeah,
see, I think.
co-host, no problem. Thank you for reminding that. So Chaco and Harold, even I'll make Dr. Veda also a co-host just to monitor the flow. And Dr. Veda, I'll give you one more responsibility. Just keep a watch on the YouTube. If there is any disconnect in the YouTube, please update us immediately so that if there is a problem with the YouTube link or YouTube live, just let us know, and also keep us posted so that we can act on that. So total YouTube responsibility is yours. Any YouTube related challenges, please feel free to reach out to me immediately. So Dr. Rupa, I'm also making you a co-host. Elliot, let us make all Julie serves the mobile, right?
Yeah.
So okay.
Two people are there in the waiting room, Doctor.
Yeah, hold on till 3:30. Elliot, are you ready with the music and the background? So that by 3:30 we'll be muting our cameras and you have to take care of the screen and then the background music and all. Just check once, the rooms, breakout rooms, Elliot. I'm trying to create one, just for us to understand.
Yes, it is there. You want me to break out and see now? Or?
Yeah. Because if we can break all 5 of us into 4 groups.
The YouTube link. Herald sir, please give me the YouTube link on the.
It's there in the chat in Zoom, Dr. Veda.
Just let me see.
Or else I'll copy to you.
Hmm.
Just give me a minute. Elliot, could you break out the group?
Yes, sir, on it.
Yeah, now I can see the group.
What is the name for the breakout room?
Group 4.
What is the time that?
Elliot, there are only 3 groups, right?
Yes, sir. Now we have made 3 groups. We can make 4 groups or any number.
So you don't have any problem with that?
No, sir.
Okay, no problem then. So now it is 3:30.
Hi, Dr. Satish.
Hi. Hello, everyone.
Good evening.
You can hear me well, no?
Yes.
Okay.
Hello, Dr. Satish.
Hello.
Hello, sir.
So what's the stand? Shall we allow people in? There's one Brian Lawrence entered. I don't know if they're Indians or.
Yeah, he's an anesthetist at Scudder Memorial.
Yes.
Okay.
Yeah.
He worked earlier in Kodaikanal for some time.
Yeah. So he's already in, I believe. So Elliot.
Yes.
Yeah.
Yes, sir. Can send that 3 or 4 to Dr. Satish, sir.
Pardon?
Ashita ma'am's breakout room, case study 4. Can I share it with Satish, sir?
He's asked Dr. Rupa.
Ma'am?
Yes.
Yeah, share it.
Okay, then. So I'll be muting my camera. I'm sure you can have liberty to mute. Anyway, Elliot is going to share the screen and play some background music. We get ready. Elliot, who's going to pray the beginning?
Rupa ma'am will pray, sir.
Yeah, okay. So Dr. Rupa, we request you to start the program with the opening prayer at 3:50.
Sure.
Okay. Okay then. So Elliot, over to you, ma. Wait a minute. Can all of us have a word of prayer before we Harold, why don't you pray for all of us?
So, gracious Father, we thank you for this evening. Thank you for this technology because of which we could connect from afar. Thank you for giving us resource people, blessing them with your wisdom and expertise. Pray for the ones who will be joining, for our General Secretary and all the staff of EMFI putting this thing together. Pray that through all that is being done, may your name be glorified. May your kingdom come into our country, Lord, through all that the deliberation which will happen for the next few hours through the Center of Bioethics. Pray for Dr. Rupa and her team as well. Father, that things will become clear for the ones who have doubts in these areas, and may the learning continue for the glory of your name. In Jesus' name I pray. Amen.
Yeah, Elliot, over to you.
When you are discouraged, thinking all is lost, count your many blessings, name them one by one, and it will surprise you what the Lord has done. Count your blessings, name them one by one. Count your blessings, see what God has done. Count your blessings, name them one by one. Count your many blessings, see what God has done. Are you ever burdened with a load of care? Does the cross seem heavy you are called to bear? Count your many blessings, every doubt will fly, and you will be singing as the days go by. Count your blessings, name them one by one. Count your blessings, see what God has done. Count your blessings, name them one by one. Count your many blessings, see what God has done. So amid the conflict, whether great or small, do not be discouraged, God is over all. Count your many blessings, angels will attend. Help and comfort give you to your journey's end. Count your blessings, name them one by one. Count your blessings, see what God has done. Count your blessings, name them one by one. Count your many blessings, see what God has done. Count your blessings, name them one by one. Count your blessings, see what God has done.
Good evening, everyone. A very warm welcome to all who are present here. We have a lot to cover today, so we'll just start off. So I request Dr. Rupa ma'am to do the opening.
Thank you, Elliot. Shall we all just close our eyes in prayer? Lord, our gracious Heavenly Father, thank you, Lord, for bringing us into your presence this beautiful afternoon. Thank you so that we could come into your presence today, asking for your guidance, your wisdom, and your support as we begin this meeting today. Thank you for providing us technology that so many numerous number of people could come into one platform in so many different parts of the world, Lord. Help each one of us to engage in manifest discussions and allow us to grow closer to you as groups and help us know and learn things which may be issues pondering in our minds, Lord. Help us as learners and provide us to engage on the road of learning so that we can grasp the knowledge and lessons before us. Clear our mind of all the distractions, Lord, and also provide all the needed help to all the organizing teams and to take care of any technical glitches or problems that may be on the way, Lord. Help us that we may be blessed by this time, Lord. Lord, we commit this time especially into your hands, asking to be with each one of us, guiding through us, and helping us through these sessions that we may spread your love through the healing ministry that you have called us to be as healthcare providers, Lord. We ask this all in your mighty and precious name. Amen.
Thank you, ma'am. Now I request our General Secretary, Dr. Sukumar, to kindly welcome the delegates.
It's a very good afternoon, and good afternoon, Dr. Rupa. It's a privilege and it's God-given opportunity for all of us to do a session on bioethics. As you see, the world is changing and the dynamics in healthcare and in life sciences are also changing. And, it's important for us as children of God to equip ourselves, update ourselves on the contemporary, the scientific knowledge and update ourselves with the challenges and adequate knowledge to combat the challenges that we are facing on a day-to-day situation. As you see here, as you see across the world, the momentum for autonomy is growing phenomenally. The civil liberties, autonomy, and person-centric ambitions are growing phenomenally across the world, wherein the conflict between the ethically mandated behavior and a person-centric behavior is a day-to-day phenomena. And in that context, what we are living in a world wherein every day it comes with its own challenges in ethics and a behavior which is in line with the biblical perspective. For a child of God, it will be a challenging situation. So we thank God for enabling us and the Center for Bioethics, especially Dr. Rupa and even the entire team from TCB, for making this possible. And even all the sessions that were planned are strategically planned, including, breakout sessions. Apart from breakout sessions, there's a plenary there and Q&A to address all the challenges. Though bioethics is a new topic for some of us, I'm sure, these sessions would give us, a breakthrough in our understanding in bioethics. And I see this as a beginning for the greater things to come in bioethics and in our engagement with bioethics in the days to come. And with the Lord's help and with the help of TCB, EMFI is willing to host many such events in the days to come. And I thank each one of you for taking efforts to join today's session. And I'm sure it's going to be a blessing to each one of you and to us to look forward for the greater things. We thank God and praise God. And let's have a blessed session. Thank you.
Thank you, sir. And I call upon Dr. Chako, who's based in Bangalore, to address the delegates with a welcome.
Yeah, thank you, Dr. Elliot. So I'm Chako, and I'm here to give you some updates about today's program. So the first session for today is on autonomy and its practical aspects, and it will be led by Dr. Ashita Singh. This will be followed by Dr. Satish Thomas's session on beneficence. Dr. Jamila George will be leading the third session, and this will be on justice. Dr. Priya John will address the topic non-maleficence. This will be followed by Dr. Rupa Varghese session on bioethics and law. And the final session, the plenary one, is on the basis of bioethics, and this will be led by Dr. Santosh Matthew. So welcome everyone, and in case you're finding any difficulty in connecting to the Zoom platform, please do let us know. We'll be happy to help you. So thank you and have a blessed conference. Over to Dr. Elliot.
Thank you, Dr. Chako. Next, we'll have the session by Dr. Ashita ma'am. Just a brief intro of Dr. Ashita. Dr. Ashita had earlier worked in Emmanuel Hospital Association in Baptist Christian Hospital Tejpur in Assam for 7 years post her general medicine, and thereafter 3 years at CMC Vellore in training in ICU, and also now she's working in EHA Chinchpada Christian Hospital. She also heads the EHA Palliative Care Service, overseeing about 18 palliative care programs across EHA rural North Indian locations. These programs take home-based palliative care to some of the most marginalized people in the country, caring for them and providing relief and comfort towards the end of their lives. Ashita ma'am is married to Dr. Deepak sir, who is a pediatric surgeon, and they are blessed with 2 children, Arnav and Tara. We are so delighted to have you, ma'am. Over to you, ma'am. Ma'am, you're muted, ma'am. Ma'am, you're muted. Oh, okay. Okay. Yeah, now you.
Okay, thank you. Are you able to hear me? And can you see me well? Okay. Okay, good afternoon to everybody, and it's lovely to be here on this platform. I'm really, so glad that we have such a lovely turnout, so many people on this learning platform. So, Elizabeth, is it possible for me to share my screen so that it'll be easier for me to navigate it, if you can enable that as well? But otherwise, if that's not possible, then you can share the screen. Okay, so that's Elizabeth sharing the screen. The only problem with this is I'll have to keep saying next. Okay. Okay, I'm the co-host now. Okay.
Yeah, you can do that.
Yeah, I think that'll be better if I'm able to. Are you able to see the screen now?
It's not full screen yet.
Yes, I'll make it full screen. Yeah?
Yes, thank you.
Okay. So, Elizabeth, can you just let me know till what time does this session go so that I can plan the time accordingly? It's 3:55 now.
Yes, ma'am. 4:15, ma'am.
Okay. Oh, 4:15 is it? 20 minutes.
Yes, ma'am.
Okay.
We have to have a breakout room. No?
Okay. No. So including the breakout room, we have till what time?
4:40.
4:40. Okay, thank you. So what I'll do is I will just take us through a few basic aspects of autonomy, so that when we go into our breakout rooms, we will have something useful to discuss. So I'm sure all of us would have heard about autonomy. I think everybody else needs to mute themselves, please. There are some sounds in the background. Okay, so what is autonomy? Okay, before I start, can we just have a quick word of prayer? Just pray. Father in heaven, we thank you so much for this opportunity to learn together, Lord. We commit ourselves into your hands and we pray that as we talk about these things that are really important to you, that are really precious to you, that are high priority for you, Lord, but that is not very important in the eyes of the world. But we thank you that you've chosen us to be separate from the world. You've chosen us to practice and live in a way that is in keeping with your character. And so, Lord, help us to understand these concepts from your eyes, Lord Jesus, and help us to be people who will be equipped to respond to all the things that come at us in the world, and help us to be equipped to live in a way that really honors you, that displays your character, Lord Jesus. And so we commit this whole time of learning together into your hands. In Jesus' name we pray. Amen. Okay. So what is autonomy? Autonomy is the freedom to determine one's own actions or behavior, or freedom from external control or influence. So we all know, we all have heard about this term autonomy. And another way of saying it, it's a decision making which is voluntary. That means I make it on my own and without coercion. What is coercion? Coercion is sometimes when undue pressure is put on someone to make a decision that we want them to make. And this undue pressure can be positive, it can be negative. Sometimes we may give them, they may be made afraid of the consequences if they don't agree. That is a negative side, but coercion is a positive side, where we say, all the people who are participating in this study will get 5,000 rupees. And that is much more than what would be required for the purpose of the study. So that would amount to coercion. So decision making, which is voluntary and without coercion. And another way of saying it is voluntary rational choice. Okay. So in the bioethics language, when we talk about autonomy, often it comes up when we are talking about informed consent. So when we are taking consent from a patient, either it is for a medical procedure, it may be informed consent for participating in a research study, or for surgery, or for various things. So in bioethics, autonomy often comes into play when we are dealing with informed consent. But it is much more than just informed consent, and very often we will, you will recognize that we have it is possible for us to violate the autonomy of people even in normal situations. For example, if there is a patient who has a very life-threatening disease and we decide not to tell them about the diagnosis, but we tell only the family, we don't tell the patient. There is no informed consent involved here, but there is definitely a violation of autonomy, because knowledge about the patient's condition belongs to the patient. It does not belong to the family, neither actually does it belong to the doctor. For the doctors, we just have the privilege of holding that information, which actually belongs to the patient. So not giving it to them would mean that we are violating their autonomy. So that's just for you to think about how autonomy is wider than informed consent. But informed consent is one of the important ways in which autonomy is expressed. So Beauchamp and Childress said, it is a right to hold views, make choices, take actions according to personal views and beliefs. Okay, so whatever is my value system, according to that, I am able to express my desires and to make choices. Now, what is valid informed consent? Valid informed consent is when there is a competent decision maker. That means by law, he's competent. Somebody who's an adult is somebody who gives valid informed consent. Competent decision maker who is given adequate information. Okay, that means we cannot give them just a superficial piece of information and expect them to make a decision. They must be given all the information that is required for them to make a good choice. That means what we are suggesting, what are the pros and cons, all the information must be given. And then it must be a voluntary decision without coercion. That means the decision must be made by the person without coercion. So what is adequate information? First, it is important to tell people what is the reason for the intervention. Secondly, they must know what are the benefits, what are the risks, what are the burdens. You know, sometimes when we want people to agree to a certain intervention, we'll just simply tell them this is very important for for your patient, so you must sign this because otherwise your patient is likely to die. But it's very important for us to give in detail the benefits, risks, and burdens. We must also give any alternate options that are there apart from the intervention that we are suggesting. And then we must discuss what are the benefits, risks, and burdens of the alternatives that we are suggesting. Then we must also tell them what is the likely outcome without the intervention. You know, what is likely to happen if they choose not to take this intervention. And then based on all this information, we must give them what our recommendations are. So when we make a recommendation, that is after giving them all the information about all these other points that I have mentioned. Remember that although we want the patient to make a voluntary choice, it is okay to try and persuade them to agree with our recommendation. And I'm sure that many of you would have, you know, in your different, you will be in different seasons of your professional life. Some of you are medical students, some of you may be professionals, medical professionals already practicing. And you would often have come across situations, or you would have witnessed situations where we try to persuade people to make a decision that we feel is good for them to take, right? So that persuasion is acceptable as long as we don't distort information or as long as we don't withhold information. So simply because we want them to agree to a procedure which we feel that is beneficial for them, it is not okay if we withhold from them the knowledge about the possible side effects or the possible risks that are involved in that. So without withholding or distorting information, we can persuade. So that is in keeping with valid informed consent. Now, another concept in autonomy is to think about two orders of autonomy. You know, autonomy is when a person makes their own choice. In simple words, that's the way we understand autonomy. But first order and second order autonomy is something that we in our Indian context need to understand and need to be able to appreciate. Otherwise, we will often think that, you know, autonomy is not being upheld when it actually is. First order autonomy is when the person themselves make a decision about right or wrong, about what they order. Autonomy is when the autonomous choice to yield the first order autonomy to another person. That means I am ill and there is a decision that has to be made about my surgery, but I'm going to tell my parents, you please make the decision. I'm competent. I am an adult. Everything is, you know, I have the right to say yes or no and say, I am happy to do. Right? So that is the autonomy. I just am I audible?
Yes, yes.
Yes, ma'am.
Yes.
Okay. Then another concept that we need to understand when talking about autonomy is competence and capacity. Okay, so what is competence? Competence is a global concept. It is typically made by a judge in a legal setting to say that a person is competent. And in general, we say that adults, that means once they are over 18 years of age, are competent to make a decision and they can give valid informed consent. Of course, there is also mature minors who are in a position to understand their situations and their assent is which is different from competence. They may occasionally or for some time lose the ability to make decisions, and because of the hyponatremia, their ability to make decisions drops because they may go into altered sensorium if the hyponatremia is very severe. And it is possible that tomorrow or day after they will regain consciousness and they will their decision-making capacity will be restored. Okay, so there may be a certain clinical condition that is making them incapacitated to make a decision, and this can be dynamic or fluctuating. Okay, another concept when we talk about autonomy is surrogate decision making. That is, when patients lack decision making capacity, informed consent is given by a surrogate. That means it's given by somebody else other than the patient or other than the person. So this should only come into play when decision-making capacity is lost. Okay, surrogate decision-making should ideally be made by someone who knows the patient well and is aware of their wishes. And it is important to recognize that surrogate, the person who makes the decision, usually is a member of their family, especially in our Indian culture. But often it can be someone else who knows the person very well. It may be a colleague, or it may be a very close friend who knows what the person is like and what they want, right? So there are two standards for surrogate decision making. That means what is the way in which can everyone please mute? What is the way in which the surrogate should make a decision? So the first one is the substituted judgment standard. And the second one is called the best interest standard. Okay, so the substituted judgment standard is the preferred standard. And that is a process of arriving at a decision that the patient would make if they were able, based on their wishes or known values. So that means if somebody already knows that this is what the person wants, even when they lose decision-making capacity, then the surrogate will make a similar decision based on what the person wants, what the patient would have wanted, So it's not a decision that the surrogate makes based on what they want or based on what the surrogate thinks is good. But the surrogate should make a decision based on the patient's own wishes and values. So that is the preferred judgment for making surrogate decision making. And the second standard is called the best interest standard. That means if you are the surrogate decision maker, you make a decision based on what most people would choose in that same circumstance, or what you think would be in the best interest of the patient. So I hope you understand the difference between a substituted judgment and best interest. Best interest is what most people would want, whereas substituted judgment is very specific to what that person actually wanted. So now it's very important for us to keep in mind certain kinds of people whose autonomy is often violated, certain groups of people whose autonomy is often, just ignored. And this can be children, because they are weak and they don't have a voice and they may not be in a position to make good decisions for themselves. Pregnant women, neonates, fetuses. Do you recognize that a fetus is a person? A fetus in the womb is a person created in God's image and therefore worthy of dignity and respect. So fetuses, dignity can be violated. Prisoners, people who are mentally disabled, people who are educationally or economically disadvantaged. Such people have their rights at risk, and all of us in this conference, on this platform, must protect the rights of people in these special groups who are more vulnerable. Okay. The concept of autonomy actually came in a little late into bioethics. And initially it used to be about, beneficence and not doing harm and about equitable justice. But autonomy came in mainly after the horrific Nuremberg trial experiments. You must have heard of the time when, people were forced to be part of very life-threatening research, in engagements which actually cost many people their lives. And at that time is when autonomy became more important And so it is important to remember that in the West, the understanding of autonomy is more individualistic. How can the individual's rights be protected? How can the individual have the right to make their own decision? How can the integrity of that individual be maintained? Whereas in the non-Western world, the understanding of autonomy is more interdependent, more community oriented, and because many of our people in our cultures find their autonomy, find their identity more in their communities. So in the West, it's more individualistic, whereas in non-Western communities, it is more interdependent. And I love the statement which Nedelsky makes: autonomy must be reconceived as a participatory capacity and not deny dependence, but may work to transform it. Autonomy is not about trying to keep others out so much as ensuring that individuals are effectively empowered when interacting with one another. So it's not about, it's just me, I myself alone have to make the decision, but to ensure that I am empowered to make the best decision that I can in keeping with my values. And to give a biblical perspective, we know that the concept of autonomy is very important for us as Christians, because the autonomy is based on the understanding of dignity of people grounded in Imago Dei, that is, their creation in the image of God. So because people are created in the image of God, it is important for us to give them respect. And who all are the people who are created in God's image? It is people like us who have good capacity. It is people like us who are elite and rich and educated. But it is also people who are who do not have the capacities to perform, people with severe disabilities, people who are maybe unconscious and on the ventilator, people who are completely illiterate, people who are, disempowered, people who are in the womb. All these are people who are worthy of dignity because they are all created in the image of God. And a wonderful example of how autonomy, we should think about autonomy is within the relationship that is there in the Trinity. We always, it's amazing to see how God the Father, God the Son, and God the Holy Spirit live in a beautiful relationship with each other. They are constantly affirming each other. They belong to each other and have an interdependent relationship. And in that, they are completely secure because they are completely loved. And we know how in Gethsemane, when Jesus was asking, Father, if it is possible, please take this cup from me, but not my will, but yours be done. So Jesus was expressing himself, and yet he was surrendering to the authority of the Father, and that was a voluntary surrender. He was not bound hand and foot and taken to his death against his wishes, but he voluntarily laid down his wishes before the Father. So this is a wonderful example for us to think about how autonomy can be practiced even in our relationships. And our identity in Christ lends a security that sets us free to make an autonomous choice to subservience in relationships. That means because we are free in Christ, because we know who we are in Christ, it is possible for us to enjoy an autonomy along with an interdependence and along with a sense of community. And this kind of autonomy rejects both extremes of idolatry. That means we are not veering towards self-centered, over-assertive individualism. Neither are we completely veering towards the other center. That means saying, oh, we are nothing and you are everything and you make all the decisions. But we are within a flourishing relationship where autonomy and identity and respect can flourish. Okay, so having given this slight background about autonomy, I think Elizabeth, we are ready to go into our breakout group.
Yes,
and
ma'am.
just to give a primer, you will have there are 4 case scenarios that we have, and we have time till 4:45. So what we will do is we will have a discussion for about 8 minutes. Is that possible? If the scenarios will be shared in the groups, and the scenario is being shared in the groups, they are quite simple scenarios, and there are some questions at the end of the scenario. So if there could be a facilitator in the group who would help, it would be wonderful if everyone can contribute and be let the session be nice and jammed with lots of opinions rather than silence, because I think these are things which we learn a lot from discussing with each other and talking to each other. So once we have had the breakout rooms, then we'll come back and we'll quickly go over the 4 scenarios, depending on how much time we have. Okay, over to Elizabeth.
We'll just break you out in 4 groups so that one group leader will be Dr. Sukma sir, and the second group leader will be Dr. Rupa. Third, Ashita ma'am will take up the room, and 4th room will go by Dr. Satish Thomas. So we'll just break the participants into 4 groups, and yeah.
Elliot, you said group 3, but mine says room 4. Is that okay?
Okay, ma'am. Yeah.
எலிட் ஹெரல்ட் பேசுகிறேன். ஸோ இங்கே இருக்கிறவங்க எல்லாருக்குமே ரூம்ஸ் அலாட் ஆயிடுச்சா? பீப்புள் ஹவ் நாட் ஜாயின்ட். ஷுட் வி சென்ட் அ ரிமைண்டர்?
വേറൊരു മിഷണറി ആയിരുന്നു.
So we are back in the main session.
Ma'am, you can continue, ma'am.
Okay, sure. Okay, so group one who had Jiva Bai. For everyone's benefit, I'll just quickly read the case. Jiva Bai is a 25-year-old nulliparous woman, lady, who has been married for 2 years and is otherwise well. She was brought to the hospital with short duration of abdominal pain and faintness. She was evaluated and diagnosed as having a ruptured ectopic pregnancy with hemoperitoneum and severe blood loss anemia, though at present she was hemodynamically stable. She is advised immediate surgical treatment. Jivabai's family members are unwilling for her to undergo surgery because they believe that this will preclude the chances of her having children in future. They feel that if they go through surgery, she will not have any children. They also feel that there is a local Maharaj who will be able to cure her without surgery and are keen to take her there at the earliest. Jivabai, like the rest of her family, is illiterate. After detailed explanation of her condition, including the risk to her life without surgery, she is unsure. The family is adamant on taking her away, fearing that delay will cause harm to her life. She is, however, unwilling to consent for surgery against her family's wishes. Okay. So the question is it ethically permissible to honor this lady's request for discharge against medical advice, knowing that this could put her life in danger? And what can we do in this situation? So group 1, can you share what you discussed in your group?
Dr. Ashita, we couldn't discuss much because of various reasons.
Okay.
I think you can continue because topic itself is new to many. Number 2 is some of them might have joined in between.
Okay.
So there wasn't much interaction, so we can continue and
Sure.
help others. Yeah.
Sure. Okay. So, yeah. So can we just put in the chat box? Let's put in the chat box. How many of us think that we should? So if you think that we should discharge this lady and let her go, and that would be the right display, that would be in keeping with the display of autonomy, can you put a yes in the chat box? We should discharge her. Okay. Annie's saying we should not discharge her. There are 1 or 2 no's. It'll be too risky to discharge. In fact, yes, she could die. Mercy is saying, could we transfuse blood and discharge her? But they are in a big hurry. They want to just leave immediately because that Maharaj is waiting to save her life, no? So there are about half and half, yes and no. So what do you think we can do? Okay. So some of us feel it is not right to discharge her. Dr. Priyaki is saying, counsel the family members and explain the risks and benefits. We have already done this. We have already tried our best to explain, and they are just not willing. So what are we going to do? Someone is saying, yeah, if we have to, it's not right, but if we have to, then there must be proper documentation. Okay, I think all these are wonderful. I think you get the conflict, the conflict in our hearts. Can we overrule her? Do you think, okay, I'll frame the question differently and put again in the chat box. Do you think we can overrule her, hesitation, or overrule her? She's not willing to sign, but we just take her to surgery and do off the surgery and save her life. Will that be the right thing to do? Okay, that's a clear no, right? That's a clear no. Thank you. And that is absolutely right. So why is that not an option? That is not an option because if we overrule her choice, then that is a violation of autonomy. We cannot do that, right? Okay, somebody's saying if there's no active bleeding, we can do transfusion and manage without surgery. That would be quite risky as well because we know there's ruptured ectopic bleeding inside. She's very anemic. Okay, there's a small chance that she may make it, but that would not be really optimal, right? So what else can we do in this situation? They want to go to the Maharaj. Anyone has any ideas of what we can do to save the situation, save this lady maybe?
Ma'am, the doctor can take the decision on basis of beneficence, like to do good to this patient.
That's so what do we think? Can we say that okay, I see some interesting recommendations in the chat, but before that, can we say based on beneficence, we know without surgery she's dying, with surgery she can live, it's a simple surgery, but of course there is some risk. She's anemic, she's very anemic, anything can happen during the surgery as well. She's not giving consent, we just wheel her into the theater, we are trying to do good, we should operate. What do you think? Doing that would actually be a violation of autonomy. We can explain to her as much as we can, but in the end she must say yes before we take her for surgery. Okay, so that's the bottom line. So Jeevan had a suggestion. He says call the Maharaj. You think that's an option? I think that's an option. So when we are thinking of autonomy over here, yeah, thank you so much for all your suggestions in the chat. Jiva Pai is competent, right? She's an adult and she has intact decision-making capacity. She is fully competent and she has full capacity. She's in her senses. She's not in shock, altered sensorium. She is exercising autonomy and she is saying that she will only agree if her family says yes. She's very much involved in the decision-making. She is the one who's choosing to defer the decision to her family members. Okay. So her decision is clear, although it conflicts with medical advice. So actually in saying no, she is exercising her autonomy. But we are not happy with her decision because it is a dangerous decision. So what can we do? So we can try to arrange a meeting with the traditional healer, and it may be possible that we can explain the problem to him, and he, with a lot of interaction with some of these traditional healers, they are not very unreasonable people. You can tell him what the problem is and say, will you be able to help them? And then right there and then he might say, actually no. Or he might say, I'm going to put this thread. Will you allow me to put this thread around her neck? And that might save her life. Say, okay, please go ahead and put the thread, but will you still, along with the thread, allow us to do the surgery? And then we may be able to save the situation and we may be able to save her life, and they will be satisfied. Traditional healers been taken there, his involvement has been sought, and we may be able to go ahead with the surgery. Then if they don't agree, we can also say, please go and try, but go quickly. And if your traditional healer says, no, you need to have surgery, come right back. So leave our doors open. So that they have the option of returning. Sometimes it so happens that we get so angry with them, and they're not listening to us and they're going away, go and do what you like and don't come back. But if we are generous and if we are humble and we tell them that they can come back, then sometimes, very often, we've seen that to work. And another thing is sometimes the cost of the surgery may be the thing that's standing in the way of them, making the right decision. So even if they don't mention it, it is good for us to just check, is that what is holding them back? Is the fear of the cost of surgery the thing that is coming in the way? Yeah, so we can clarify those things. So open conversations. And in this bargain, sometimes when people recognize that we really care about them, that we really want them to, get well, they might agree and we might win the situation. Any comments on this or any other perspectives? Okay, yeah. Jeevan is saying we should make sure that we are being honest in our communication. And if there are details that the patient needs to know, it's very important for that to happen. Yeah. Okay, thank you. So we'll go to the next case. The next scenario. I'm sorry, when it is on full screen, I'm not able to. There are things I'm not. Yeah. So, okay. Jairam has been brought to the hospital with severe abdominal pain for the last 2 hours. He's been evaluated and found to have a duodenal perforation requiring surgery. He is under the influence of alcohol and vehemently shouting his refusal of surgery, saying he is afraid of dying and will not consent to surgery. He is also speaking irrelevantly in between, and as well as asking for more alcohol to reduce the pain. He also has cardiac disease, which increases his operative risk. His family members understand the need for surgery and are willing for him to undergo the same, although they are anxious about the increased risk and his vehement refusal. Okay. So group 2, were you able to have any discussions on this case? So here is this alcoholic man, inebriated and with a duodenal ulcer perforation, refusing surgery. He also has cardiac disease, so the operative risk is also slightly high. His family members understand, but they are very worried because he is not agreeing. So is it ethically permissible to restrain this patient and operate on him over his objection?
Yeah, Dr. Ashita, we had a good discussion. So I think either Annie or Rachel will be presenting to you.
Sure. Please go ahead.
Yes, so based on our discussion that we had, yes, it would be ethically permissible to, um, go forward with the surgery without taking the consent of the patient. But in this case, we'll be opting for the surrogate consent of the family.
Okay.
Yeah, so that's what we had.
Sure. And why is that?
Because the patient himself is not in a condition to make a informed consent for his own health and his own safety.
Oh, so this is a patient who has lost decision-making capacity, and so now the decision will be made by a surrogate. So it's very important to understand that decision-making capacity is lost, and the issues here is that it's a high chance of recovery even with the increased risk from cardiac disease. It's a grave prognosis without surgery. The person has lost decision-making capacity. Surrogate consent is valid when decision-making capacity is lost, and remember that decision-making capacity has to be assessed with the content of the conversation. So you can have a person who's inebriated, but is talking relevantly. So we need to see what the content of the conversation is, not necessarily the fact that he is inebriated. Okay. So it is sometimes possible for someone who is inebriated to also retain decision-making capacity. But here clearly, decision-making capacity was lost, and therefore we can take surrogate consent, restrain the person, and take him for surgery against his wishes. Very much different from what we discussed in the first case. Is that clear? So the learning point here is to assess decision-making capacity, and now we have to convince the surrogates to be able to make the right decision. Okay. So I think we will go to the scenario, since we are short of time and we already had a small discussion on the third one. Fourth scenario, anybody? So I'll read out the case. Ramila is a 35-year-old lady with 3 young children. She has been recently diagnosed with stage 2 carcinoma of the breast that is amenable to treatment. However, she has refused all treatment for the illness despite having clearly understood the implications of her decision and the fair prognosis with treatment. She has been depressed since the time of her diagnosis, unable to sleep, barely eating, neglecting the care of her children. She is otherwise a diligent mother and resourceful, dependable member of her family. She has a large supportive family who are keen for her to undergo treatment. There are no financial limitations pertaining to her treatment as they are covered by insurance. This is a literate but not highly educated family. So Ramila is this lady and she is refusing treatment. Ethical question. Is it ethically permissible to honor this depressed young mother's refusal of treatment for a life-threatening but treatable condition? And what will you recommend? So group 4, did you have any discussions? Anyone from group 4?
Yeah, Jeevan, can you summarize what discussion we had?
Not sure if Jeevan has got good network.
Somebody else from the group?
Sir, we had a discussion.
Yes.
Even though the principle of autonomy is important in this case, but having a mother with having a woman with CA2 stage, which is amenable to treatment, the current problem is because of her depressive ailment. She is not able to give consent for the treatment. So we have to respect her autonomy, but at the same time keeping in mind that psychiatric problem has to be evaluated and treated, and then she can be fully aware of the treatment for her condition.
Correct. Thank you very much. So again, in this patient, we find that because of her depression, she has actually lost decision-making capacity. So when she's clinically depressed, her expressed wishes cannot be taken seriously. And we would like to urgently advise treatment for her depression and pursue the treatment plans for her cancer by taking the consent from the surrogate decision makers. Okay, so the learning point here again is to consider whether decision-making capacity is lost or maintained. Very often also we'll have situations where, you know, people state that they want to live, but the choices that they make are not in keeping with that goal. So when they have a certain goal that I want to become well, but they are making decisions that don't match with that goal, that is another place where we cannot just say, you know, okay, they're refusing treatment, so let them go. It is very important for us to engage deeply and get them to a point of understanding that the decision that they are trying to make is not in keeping with their goal. And only when the two, you know, when they say, okay, I don't want treatment and I know that without treatment I'm going to die, and when they are very clear about that and then they are making that choice, that would be a valid expression of autonomy. But if they are saying, you know, I want to live and I am going to live even without the surgery, there we must make every effort to make sure that the goal matches with their treatment choices. Okay, so we weren't able to discuss the third case in detail, but we've come to the end of our time. I hope that this, you know, just these few exercises, I believe that there's a lot to learn when we, you know, when we discuss around real life scenarios. All these were real life scenarios. And in real life, actually, the principle of autonomy can be quite simple, but in real life, it can be quite complex, as many of you already know. So it's helpful to learn from these and discuss together. Thank you so much. If there are any questions, I'd be happy to take.
Doctor, during the for the second example, you mentioned something. I would request you to just clarify that you mentioned that it doesn't just depend on whether the patient is capable or incapable to give consent, but it also depends on the content of that the discussion or something.
Yeah.
So I didn't really get that point.
Yeah. So for example, when someone is, for example, if they're under the influence of alcohol, there may be different levels of intoxication, right? So they may have taken alcohol, but they are actually in a position to make rational choices and decisions. And then we have to conclude that their decision-making capacity is actually preserved, right? So it's not just the fact that they have taken alcohol, but actually the content of the conversation. So it is a very dynamic assessment that the healthcare professional needs to make about the decision-making capacity of the person, right? So even if the person is slightly hyponatremic, but they're not comatose and they're talking to you rationally about every other thing, then there is no reason to suppose that they are making an irrational choice about the intervention. So the content of the conversation, so it is up to us to really make an assessment about whether our patient has maintained, you know, preserved decision-making capacity or not. Do you understand? I hope that's clear.
Yeah. Thank you.
Okay. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you so much for sharing it and resharing it, the breakout rooms or things also again, ma'am, so that it could have helped many to understand other case scenarios as well. So next we'll go to the next session by Dr. Satish Thomas. Dr. Satish Thomas did his postgraduate ophthalmology training from a prestigious Dr. Rajendra Prasad Center of Ophthalmic Sciences, AIMS in New Delhi, after completing his UG in a government medical college in Kottayam. He has been awarded as a membership of National Academy of Medical Science in Ophthalm. He has super specialized in pediatric ophthalm and also been the first in the country to undergo a training in Shankar Nethralaya Fellowship in Chennai. He's been awarded the Fellowship of International Council of Ophthalmology in Pediatric Ophthalmology and Strabismus, following a stint at the Children's Hospital in Westmead, Sydney. He has performed more than 60 eye surgical camps in rural settings and mission hospitals in various places like Punjab, Himachal, Uttarakhand, Haryana, Jammu, and UP. His articles has been published in 9 international and 10 national peer-reviewed journals. It's a great pleasure to have you on board, sir.
Yeah,
Over
thank
to
you, Elizabeth. Can I share my screen? Am I enabled?
Yes, sir.
Thank you. Is it okay? Can you see it?
Yes.
Okay, yeah. Okay, so thank you, EMFI and the organizers for giving me this opportunity, and greetings to all the participants. So this session is on beneficence and how this bioethical principle we should keep in mind when we take ethical decision making, how the principle of beneficence ought to shape our ethical decision making. So in the previous session on autonomy, an unsaid principle that we were considering was beneficence. And we will look at that in more detail in this session. In much of the clinical scenarios that we were discussing last in Ashita's session, we automatically used beneficence as one of the principles. And we will look at that in this session. So the case scenarios actually are not much different. So, and since I will not be doing breakout groups, I think we will have a lot more time at our hand. So I encourage all of you to actually engage in discussions and even raise questions. So what is beneficence? It is an ethical principle where the clinicians and researchers, so because this applies both for clinical scenarios as well as in research, where we uphold the benefit of patients and the research subjects as our goal. So the welfare of the patients and the subjects is the goal. This might appear very obvious, isn't it, to many of us? But it actually, philosophically, when we look, it need not be very obvious. And that is something, again, that we can consider in some of our ethical thinking. Because what are the foundations on which we base our decisions? For example, we can think about why should we uphold beneficence more than maleficence? Why should we consider the good of patients rather than their harm? Philosophically thinking, even why is good better than bad? And if we ask such sort of uncomfortable questions, then we will philosophically have to go back to invoking a God whose character is good. Unless we go back to that foundation, we cannot say why good is better than bad or beneficence is better than maleficence. So using some of these philosophical deliberations, we can bring people back to thinking about their worldview. That's one of the ways for us Christians to actually use ethics to make people think about their worldviews and draw them towards God. So anyway, that's a matter for another discussion, but something that some of us who are interested can engage in. So beneficence though it might appear very self-evident and obvious to us, the reason it appears so is because of our history. We have been in this brand of medicine, which is called the Hippocratic the Judeo-Christian brand of medicine for the last, say, 2,500 years. So it appears as if the beneficence is self-evident. But especially if you read history of how Hippocratic medicine became the predominant form of medicine, at least in the Western world, you will find that it was competing against the other forms of medicine, which were not really seeking the benefit of the patient as the primary goal. And that is why it was the Hippocratic brand of medicine that really made medicine an ethical enterprise. Why is ethics upheld so much in medicine? The primary reason is because of this brand of medicine historically. Let me read this statement by Edmund Pellegrino, one of the predominant Christian bioethicists who has done a lot of work. He says that beneficence is the sole foundational principle of professional medical ethics. So we are now discussing 4 bioethical principles, isn't it? One after the other. Ashita's session on autonomy, then we have beneficence here, and the next 2 sessions on justice and non-maleficence. So these are considered the 4 primary bioethical principles. Of this, I want to say that beneficence is primary because that is the goal for which medicine exists. The reason or the goal for which a person should be entering into the discipline or the profession of medicine is so that he can benefit the patient. And if that is the goal, then what are the other principles that he must seek to uphold? He must seek to uphold the autonomy of the patient. He must not harm the patient. He must also consider justice and things like that. But beneficence is the goal towards which, for which he must even be entering the very discipline of medicine. Sometimes this can be so self-evident or obvious that we do not consider it as so important in our discussion. Why I'm saying is that we might miss the wood among the trees when it comes to beneficence. So here's a case scenario as a trigger case scenario. As I said, the scenario is not very different from something that we have already considered in the previous thing. But so we will not break into breakout groups. So let me just read it out and we can have the discussion as a large group itself. A 20-year-old college student living in the college hostel is brought by a friend to the emergency department because of unrelenting headache and fever. He appeared drowsy, but was responsive and had fever and neck rigidity on examination. A lumbar puncture was done, and the spinal fluid appeared cloudy and showed increased white cells. Gram stain showed gram-positive diplococci. Based on the diagnosis of bacterial meningitis, appropriate antibiotics were begun and hospitalization was instituted. Although an initial consent for diagnosis was implicit and consent for lumbar puncture was explicit, at this point, the patient refuses treatment without giving any reason, and he insists on returning to his hostel. Even after explanation by the physician as to the seriousness of his diagnosis and the absolute need for prompt treatment because of danger to life without treatment, the patient is adamant in his refusal. Okay, I hope you have sort of grasped this case scenario. We can all quietly read it for about another minute. And then we will go to the questions. So now I've put the first question there up on the screen. You can think about that. How do the bioethical principles of autonomy and beneficence apply to this case? So before anybody speaks up, I would request all of you to consider these two principles, both autonomy separately and beneficence separately. And can you think about how these two principles would apply to various parts of this case scenario? Think about it for a minute, and then I will invite your responses openly on the group. You can just unmute and speak up. All right. Can we have responses on the common group, please? Any of you can just unmute and speak up.
So there's a question on the chat box, sir. What is it and explain?
One second. Let me just try and see that. I'm not able to see that because I think I'm full screen. Can you read out the question, please?
What is the difference between implicit and explicit?
Okay.
Talking about the consent.
Yes. Okay. Yeah. So an implicit consent is when you do not put the question to the patient, but you assume that the consent is already there. For example, a patient comes to your outpatient clinic to see you. You do not ask the patient, do I have permission to examine you? That's already implied. That's the very reason why the patient came to you. So that's an implicit consent. And an explicit consent is when you would put the question to the patient and then get the patient's verbal consent or a written consent and then proceed. That's an explicit one. So before the LP was done, that consent was also taken and given. And it is After that, then the patient then refused treatment. I hope that is clarified.
Was the patient admitted or in the, where was the LP and other things done, sir?
It was done in the emergency, and it was when the patient was to be admitted that at that point he refused.
So since he is drowsy,
Will we get these sort of patients without admission? All these LP and other things will be done in emergency room, sir?
Yeah, that depends upon the seriousness of the condition, the acuteness of the situation.
Because in our government medical college and all, I think in such a situation, the patient will be admitted and then only they will go for LP and other investigations, sir.
Okay.
so since he is drowsy, can we say that his decision-making capacity is impaired? Could we call for a surrogate?
Yeah, those are the things that we ought to discuss. So can you?
So when autonomy here, when the autonomy or the decision-making capacity is compromised, we need to hold the beneficiaries as our guiding to do good for this patient.
Correct. So yeah. So can you just try and articulate those things? How does autonomy and beneficence apply to this case? How does in what way are you trying to apply beneficence? In what way are you trying to apply autonomy, and what are the problems that you are facing in this scenario? Can you try and articulate that?
The beneficence is to treat the patient, to do good to him, because it is an immediate thing which has to be treated. And the autonomy is like the patient is not willing to do it. But as his condition, as it was mentioned that he is drowsy, maybe he is not in any good condition or decision making capacity. And also maybe he has any other depressive episode or whatever it may be. He seems to be like not in a sound to take a decision. So.
Yeah, very good. Yes. Anybody else wants to add anything?
Should his parents be involved in this decision-making process, sir?
Yeah.
Because he is staying in the hostel.
Yeah, he's staying in the hostel. There's not yet time for that yet. Means it is an acute situation, no?
Okay.
Talking about the principle of beneficence, we really don't know what are the reasons why he's denying treatment. Maybe the benefit of doubt could be given that he probably has financial constraints, or he feels that he doesn't have the support, nobody to help him. Though his friend was the one who brought him to the emergency ward, he doesn't have family probably. So I think like what Dr. Ashita mentioned, that, we allow him to leave, but then keep our doors open for him to come back.
Okay.
I think that after diagnosing as a case of acute bacterial meningitis, it's not ethical for a patient to be sent back to the hostel. On the way, he can collapse or he can have throat convulsions, and then it becomes very serious on our part.
Correct.
So better will be.
Here is an acute situation where, you don't have time to do that, to send him away and then allow the option of him coming back.
Yes.
Okay, so quickly to the next question. So when these two principles conflict, what do we do? So that's something that it's obvious to us from this scenario as well as the previous scenarios that we did, that often bioethical principles might conflict, and that's the whole nuance that we need to consider when in these kind of situations. Then what do we do? So that was something that we have already decided. So that we already discussed. So let's move on to the issue of beneficence, that See, before we came, that's something that I was wanting to highlight. Even when we did the first session on autonomy, beneficence was a principle that we just assumed, isn't it? We took it second in our session, but that was already assumed by us in our first. The reason for that is the fiduciary nature of the physician-patient relationship. And this is the bedrock upon which the Hippocratic type of medicine or the Hippocratic brand of medicine stands. Fiduciary means, it comes from the Latin word for trust. So it is the physician-patient trust relationship that is the bedrock of modern medicine. And fiduciaries always act in the best interest of their patients or clients. So this is the assumption that all of us were making in all our discussions. Now, as I told you before, it needn't always be so, isn't it? The market forces or the business forces work on an entirely different principle, the exact opposite principle, which is self-interest. I protect my self-interest at all costs. And so we have competing interests between a physician and a patient if we bring in the business model. So in the business model, it works on the principle, let the buyer beware. So you go to a shop, the shopkeeper wants to market his product. So he does his best to market his product. And the buyer, the onus is on the buyer to protect his own self-interest. So he will be guarded always because he knows that the other person would try his best to sell. And it's your job to. But what we were discussing so far as an assumed value in medicine is beneficence, where the physician is for the sake of his patient. And that is an important bioethical principle which we need to uphold if we are going to uphold an ethical practice of medicine. In fact, if we look historically, that is what differentiated Hippocratic medicine from the other forms of medicine in 500 BC in Athens, in Greece. The Hippocratic physicians took an oath that this is how we would be for our patients. I take an oath to do this and that, I would be this and that, I would practice in this manner, that manner. Those professions that they made differentiated them from the other practitioners of medicine. In fact, that is from where professionalism, the word professionalism came from the profession that they took or from the oath that they took. So we must understand that we are a profession today simply because of the profession that historically these physicians took. So if we are professionals today, this is what we profess to, that we are primarily for the benefit of our patients. So what are some of the hindrances or the obstacles that can come in the way of beneficence? One is commercialization of medicine. If medicine becomes commercialized, then that can be a hindrance or an obstacle to the beneficence of the patient. It can be at an individual level. If the physician is for himself, for his self-interest, rather than for the good of the patient, then obviously the patient's beneficence will be at risk. The same thing can happen at the level of an institution. Now it's very rarely doctors on themselves practicing by themselves, isn't it? Most of us practice in institutions. And if these institutions are primarily existing for profit, then again, the patient's beneficence is going to be at risk. So this is how the entire scenario can change. As I said before, beneficence we might assume, but is it so? Can we always take it as an assumption in the real practical scenario when the rubber meets the road? Is beneficence always upheld, or is it at risk? Insurances. Now, increasingly, medicine is being governed by insurances. The insurance policies decide what can be offered to the patient and what cannot be offered. In the Western world, it is very much so, and we are gradually going in that trajectory. So in all these cases, a patient's beneficence can be at risk. In fact, that is now what is primarily leading to suspicion in patient's mind. As I already told you before, let the buyer beware. That same kind of situation is arising in our patient's mind. And they are on guard now when they come to our hospitals, whether they are being offered investigations and treatment modalities for their benefit or for the benefit of the institution and the doctor. And this is what is leading to an increased mistrust and even violence against medical professional. So here is a cartoon here to put this humorously. Right now, I take a blue pill, a purple pill, an orange pill, a white pill, and a yellow pill. I need you to prescribe a green pill to complete my collection. More and more things are being offered. Is it for the good of the patient, or is it for the good of the medical personnel on the other side? Here is another humorous video that came to me on WhatsApp showing the commercialization of medicine. Okay. Another thing we need to consider in beneficence is this concept of paternalism. I don't know if you're familiar with this word. What paternalism means is that the doctor or the medical professional works under the assumption that he knows what is best for the patient. And therefore, he decides what is best for the patient unilaterally. That is paternalism, like how a father decides on behalf of the child. The child is not yet in a position to know what is best for the child, and therefore the father decides what is best for the child. without taking the child's preferences into consideration. So paternalism is intentionally overriding a patient's known preferences in order to benefit that person. So paternalism could actually be something that upholds beneficence, but at the same time, it could be a hindrance or an obstacle to beneficence also, because it does not really take into consideration the patient's value system. The paternalism, if you look at the broad sweep of how medicine was practiced, we will find that the historical model by which medicine was practiced majorly was paternalism. Now, as more and more awareness is coming about the patient's rights and human rights and individuals' rights, then we uphold autonomy. But the reason why paternalism can be an obstacle or a hindrance to beneficence is because much of these are value judgments. So the physician will be bringing a value judgment into the scenario. The patient also has a value judgment. And it may not be right that the physician imposes his value system or his value judgment over the patient's value judgment. And an example of this will be the quality of life judgment. Quite often, the way a patient perceives the quality of life can be different from the way a physician perceives the quality of life of the patient. Now, as we saw in that case scenario, sometimes there may be situations where we might have to exercise paternalism over the patient's autonomy. Some of those case scenarios, I'm just leaving it open, there can still be room for discussion, can be in acute emergencies. In an acute emergency, you may not have time to decide on, for example, to deliberate, to make the patient understand, to persuade the patient. If you wait for that, you've already lost the patient. So in some such scenarios where beneficence clearly, in your judgment, when beneficence, the benefit clearly overweighs the harm or the risk, you just have to go ahead. Or if you think that the patient's autonomy is impaired, like those situations we already saw, or where benefit far outweighs the risk or the harm, you might just have to go ahead with a decision like this, paternalism. Quickly moving on, another hindrance to beneficence can be consumerism. Consumerism, that model is where we just offer the patient the various options, and then the patient just chooses from the various options that are available. And if so, the patient chooses something that the physician considers harmful rather than beneficial. What do you do? That can again be a hindrance to beneficence, isn't it? Patient chooses something that the physician now considers not beneficial. For example, an investigation that the patient chooses, which the physician thinks is unnecessary or not beneficial at all in that particular scenario, or can even be harmful. That can be a hindrance. Another situation can be a patient having a condition where there is chronic pain, and the patient is demanding high doses of opioids continually in order to keep the pain under control. And the physician now has to exercise judgment on how beneficial is that going to be, or how harmful is that going to be. cosmetic surgeries, gender reassignment surgery. Now, these can all be things that the patient is now going to choose or demand it of you. And now the physician has to exercise judgment. Is that going to be beneficial or is that going to be harmful? We just do not give in to the patient's autonomy alone. We consider our own judgment of beneficence. That is what I want to bring in here. Insurances. Again, insurances will have a huge role to play in much of these decision making in these issues. So I think I have about 5 minutes left for my session. Let me quickly wrap it up with how can we act in when we have these sort of competing ethical principles to consider. Autonomy versus beneficence, beneficence versus maleficence. For example, any interventional procedure that we offer will obviously come with some level of risk or harm. So how do we balance that? And similarly, beneficence and justice. How do we navigate when these ethical principles conflict? We need to have continued discussions with the patient, not just taking their first, not just taking their yeah, I think somebody needs to mute. Yeah, thank you. So not just taking their first preference as their consent or their preference, their valid preference. We need to make them understand. And it is as much important for us to understand the patient's perspective as to make the patient understand our perspective. So we need to understand the patient's perspective if we have to uphold their autonomy. So that becomes a very important prerogative on our part. We need to address a patient's misunderstandings and concerns. As Ashita was saying, quite often the patient's goal and their choice might not tally. They might say that this is their goal, but their choice might not make sense. So that is because of a misunderstanding in their mind. So it is our duty to make them understand these things so that their choices can be in line with their values and with their goals. That onus lies on us to make them understand. And a very important means by which we can do that, when there is a conflict between, in our minds, when we understand that there is a conflict between what is going to benefit the patient and the choice that they have taken, when there is a conflict, when these two don't align, then a very important means for us to bridge that gap is persuasion. We need to try and make them understand, and we need to persuade them also to try and move from this to that. Persuasion is different from coercion. We said coercion is unacceptable, but persuasion is again important. We cannot just give them the options and say, you choose. My job is just to make you, give you all the available options. Now you have to choose. If we do that, then we are still not acting as beneficiaries for the patient. So we need to go one step further to make them understand this gap between their stated goal and value and the choice that they are taking. And that we can do by often trying to persuade them, not only them, involving their surrogates and all in that. And finally, to negotiate a mutually acceptable plan in line with their values and goals. Ultimately, we have to let the patient decide, because it's ultimately we have to uphold the patient's autonomy. So I think this case scenario we can skip. And I've almost come to the end of my time. So Elizabeth, do we stop here, or do we take 5 minutes more before the next session starts? And if so, we can go on to this case scenario. Otherwise, we can stop here.
We can go ahead, sir. We can take 5 more minutes.
Yeah, we can take 5 more minutes because I think the next session starts at 5:40. So here is another scenario that we can consider. Ravi is a 40-year-old insurance broker. He has episodes of abdominal cramps, diarrhea, and constipation. A year ago, after a detailed evaluation that included colonoscopy, he was diagnosed with irritable bowel syndrome. Dietary and lifestyle modifications that were advised haven't been really effective. On the advice of a friend, he now asks his doctor, sorry for that, to order an MRI scan because he feels something serious has been missed in his diagnosis. He refuses to discuss psychosocial issues or try serotonin reuptake inhibitors, saying that the problem is not in his head. So the issue here is now that here the patient is now demanding an MRI scan from the doctor, and the doctor feels that it really is not required in order to make the diagnosis, and that is not really going to benefit the patient. What would you advise the doctor in this case scenario? How to proceed? Okay, since we are short of time, let me ask direct questions. How many of you would opt for an MRI scan in this scenario because the patient is demanding it? Your previous treatment hasn't really helped the patient, though you are quite certain of the diagnosis, but now because the patient is demanding an MRI, how many of you would go ahead and do it? Even if you know that it's not really going to help benefit the patient. And what would be your rationale to advise that?
Sir, in the chat room, there are messages.
Okay, can you read it out, please? Yeah, or maybe I can see it here. How can we be certain it won't benefit the patient? Okay, that's one question I've seen. So, yeah, how can we be certain? So, the clinician now, as a doctor now, if I'm the one treating, I'm thinking that I am pretty certain of my diagnosis here of irritable bowel syndrome. And the clinical guidelines, what it says about irritable bowel syndrome is that the recommendations or the guidelines are all that if you are fairly certain of a clinical diagnosis and you have done a colonoscopy in the past to make sure that nothing else is going on, then these are the patients where there is a sort of a psychological element to the disease itself. So even if you're pretty certain that an MRI will turn out to be negative. And if an MRI turns out to be negative, that again is not going to sort out the patient's problem because the psychological element is there. Patient is likely to demand more and more investigations. And this is going to be an unending cycle. And for that reason, the guidelines are that don't over-investigate. And that is the reason why we are in this scenario, we say don't over-investigate. Okay, educate the patient on the futility of taking an MRI for IBS. Correct. That would be one very important way to go, like what we saw before in making the patient understand the situation, understanding the patient's perspective, persuasion. These are very important ways by which you can address the situation here. You could even involve other super specialists or subspecialists in the scenario, gastroenterologists, for example. But all this to make the patient understand the situation and how an MRI is not really going to benefit the patient. So that the beneficence factor, I just wanted to highlight here in bringing this case scenario. Okay, so due to lack of time, we'll stop here. Are there any pressing questions anybody would like to ask before we stop? A few seconds for any questions. If not, we can close our session. Okay, so thank you all for your active participation and patient listening. I hope it has benefited you. And so back to Elizabeth and over to the next sessions. Thank you all.
Explaining detailing and beneficence and autonomy in detail using a case study and the hindrances to beneficence. It was enlightening for all of us. Thank you, sir. And next session, we will go on to Dr. Jamila George ma'am's session. Dr. Jamila George has worked in Indian Evangelical Mission. She was the director of Share and Bhavan Community Health and Development Projects of Emmanuel Hospital Association. Dr. Jamila ma'am did her master's in International Research Bioethics from Monash, Australia. She was the manager for research and bioethics in EHA. She formed the Center of Bioethics. She has written bioethics modules for healthcare professionals. She has developed bioethicists in India by enabling 5 doctors to do masters in bioethics in the US. Together, she developed a postgraduate diploma in Christian bioethics in partnership with CMC Vellore. Currently, she is the academic coordinator at the Center of Bioethics for the PGDCB course and a consultant bioethics for Institutional Ethics Committee. We are so glad to have you.
Elliot, we might have to unmute Dr. Jamila.
You can unmute now, ma'am. Yes, ma'am.
Can you hear me now? Yeah? Okay. Glad to be here and to see this dream conference, bioethics conference happening. I've been dreaming about this for years, and the credit goes to Dr. Rupa, who has been able to bring it to fruition. Anyway, we'll go into our subject this afternoon. I will share my screen. Post disable participant screen sharing. Could someone please allow me to share the screen?
Now you can assign.
Okay, let me try. Yeah. Okay, the topic that has been assigned to me is justice. Now, to bring all of us to this point of justice, I thought I will share with you a couple of things. One is about clinical practice.
Ma'am, excuse me, ma'am. Can you make it full screen, ma'am? Yes, ma'am. Thank you.
Okay, sorry for that. Okay. Yeah, justice and patient care. And one thing that I want to bring to you is about clinical practice. We are all aware in our hospitals, and it is evident that many a times when very rich people or affluent people come into a labor room or any other OPD or anywhere, we tend to give more importance to them and try to be gracious, try to be kind, try to explain matters to them. But when poor people from villages come to a hospital, at times there is a difference, a discrimination that is shown, which is a form of injustice. So I am guilty of it. Most of us practicing in India could be guilty of this because unknowingly we are wired in such a way that we behave in such certain ways. So this is not only limited to clinical practice, but in research also. Some of you would have read about the Tuskegee syphilis study, which went on from 1932 to 1972, where you have the Black, that means the African Americans, being exposed to syphilis, and they were not given antibiotics even in the mid-50s as antibiotics were available. And the cause of the syphilis, primary, secondary, tertiary syphilis, ending in the death, was studied in great detail. And this was a gross injustice that was done to the African American people. So what I mean to say is healthcare, with all its goodness, contains certain things in which we have been not just in clinical practice and in research. So let's see what is justice. There are various ways in which we can articulate what justice really is. My suggestion to you is to ponder as you listen and jot down things. Our God is a God of justice. It's very highly upheld in the Bible. And we also want to be just. And many times we think that we are just. But then there could be areas where we need to pay attention, perhaps correct our ways. So as we go through these sessions, you had one on autonomy, the other one on beneficence. Can you please mute yourself?
Nana.
Elizabeth, is it you? Please mute yourself. Thank you. Okay, so justice is the quality of being just, impartial, or fair. Now, we will go through these things and then explain and see case studies where we can apply. Okay. Now, justice in health is about ensuring everyone has what they need to be healthy. And when they don't, we rally and advocate for what they define as a need. Now, we do these things sometimes, but many times we just take it as it is. We see a lot of injustice in the society where people cannot be healthy due to the environment, the basic determinants of health are not there. But then do we really pay attention to it? Now, justice in healthcare refers explicitly to the philosophical concept of distributive justice. Now, we'll expand on it a little later. This principle asserts that all patients will be treated fairly and equitably. At the outset, we all agree with this. But then when it comes to real practice, there are many difficulties. Now, justice for patients is equal treatment of equal cases. That means, according to the intensity of the disease or the seriousness, the patient should be treated equally, irrespective of other differences. It's about treating all patients the same. However, when patients' needs are more complex than others, sometimes those patients need to be treated differently. In one plane, we say that all patients should be treated same. But then patients are different, their needs are different, their seriousness are different. So we will need to treat them differently. Now, the last thing is about social justice. This refers to the fair division of resources, opportunities, and privileges in the society. Now, all these are, what shall I say, in some way or other, they play a part in a person's health and well-being that we are focusing on. Now, the next thing that we look is about justice and fairness. Now, justice is about what we deserve individually. So, justice means giving each person what he or she deserves, or in more traditional terms, giving each person his or her due. So, what a person deserves is called justice. Now, fairness is about the way we are treated in comparison to others. So, fairness means in comparison to others, how are we treated? Now, justice and fairness are closely related terms, and many times you see them being used interchangeably. But actually, there is a slight difference. Justice is about what we deserve, and fairness is about the way we are treated in comparison to others. Now, there are 4 theories of justice for those who are interested in such things. Rawlsian egalitarianism, that means justice as fairness. Now, Dawkinsian egalitarianism, equality of resources. Then Steiner and Valentin's libertarianism, that means there is common ownership. And the Nosikian libertarianism is about entitlement. Now, entitlement is a little different in the sense that it's what I'm entitled to. That means being, for example, being a person of Indian origin here, what am I entitled to? Or being a soldier, what is he or she entitled to? So that is, so these are different theories of justice. And there are 3 elements of medical justice. And as we said earlier, distributive justice is very important. We will look at it in greater detail. Then we have rights-based justice, that is respect for people's rights. In other words, prohibition of discrimination. So it's a rights-based justice. It's almost like demanding justice because it's right-based. And the third one is the legal justice. We all come under the same legal framework of our country. And so respect for law and what that means to each of us and each patient is important. Well, now we go on to the types of justice. As you see, to begin with, we said that we should be just and justice is important. And as we break down these things, you see that there are nuances in that. And here we talk about 4 different types of justice. The first one is distributive justice. This is very important for medical work. So here it is determining who gets what. And the philosopher Aristotle is the one who brought out this distributive justice in great detail. And yeah, so that is one thing. Those who are interested can read more about this. It's very interesting. The second one is about procedural justice. So determining how fairly people are treated. Fairly, when we say fairly in comparison to others, in procedural matters, how fairly are we treated? Now, I mean, a simple thing would be, the people waiting in the queue to see the physician, and if somebody tries to jump the queue, we feel it is unfair. That's unfair. Everybody should follow what is written there and what should be according to the queue, because waiting is an important matter. So things like that. The third one is about retributive justice. And this is about based on punishment for wrongdoing. Retribution means punishment. So punishment for wrongdoing. The flip side of it is when somebody does wrong in hospitals administratively, are we just and fair? Is there partiality? Are we more lenient with certain people? So these things come under retributive justice. And the last one is about restorative justice, which tries to restore relationships to rightness. So here again, as you know, in ethics, we have what is right and wrong, good and bad. So here, restoring the relationships to what is considered to be right. Now, in the distributive justice, there are different valid principles. As you see these things, you understand, okay, distributive justice is very important. It is good. But then that has so many subdivisions, an equal share or according to need, okay, according to effort, according to contribution, according to merit, and according to free market exchange. That means what you pay for. Now, a simple example at home would be, bigger children will be given more food. No? So it is not equal share, but according to need. But then if you bring chocolates, you will share them equally, perhaps. Now, in certain things, certain matters like where the remuneration is according to the effort, then the more you work, the more you bring out results, the more you'll be rewarded. And according to contribution, if you contribute so much, you will get so much, then according to merit and so on and so forth. Okay. Now, there's a difference between Aristotle and Rawls. Now, according to Aristotle, those who make more contribution enjoys more privileges, and who cannot enjoys less privilege. So this is simple arithmetic. The more you contribute, the better you will receive. But Rawls is different. It aims to assist and benefit the weaker sections of the society. Most of the time in the mission hospitals, this is what we try to do. Assist and benefit the weaker sections of society. So you're favoring those who are below a certain level to be able to enjoy the benefits or the treatment so that they also can benefit. So it's not just only the rich being able to pay and get it. Now we have a medical system which is very commercialized and like an industry where we talk about where it is referred. The patients are referred to as clients and the profit making is the aim. So we have a whole lot of things which are mixed up, and we need to bring back to the table what we believe God wants us to do, to be just, and at times to go against the tide so that people who are marginalized will also benefit. So we need to be sensitive to this issue. And many times we get sucked into a particular system or some senior people who, in colleges or wherever you study, so that our minds also become so conditioned by all that is around us. But then we need to, once and again, we need to be clear in our minds so that we can orient ourselves or reorient ourselves so that we keep justice as a very important thing in patient care. Now, I just put a few examples so that if there is anybody who is unable to follow, would understand what I'm talking about. Now, whenever we talk about distributive justice, it is a lot, or it is occurred in relationship to allotment of scarce resources. Now, many times we work in places where there are constraints to equipments or medications or organ transplants or whatever it is, no? We don't work in a place where everything is there beyond our needs, no? Superfluous, no. There are limits, and within that, then we have to see which person gets what and how should it be. Another thing is about care of uninsured parents, insured patients, sorry. It's very appalling at times. When I was an intern, we never had anything called insured parents. And now, when I went to a particular hospital, the first question they asked is, are you an insured patient or not? So the moment you say you're not insured, the whole thing changes. If you say you're insured patients, immediately they're very happy and enthusiastic to do everything. So we need to be careful. Now, how can we be just? How can I uphold justice when uninsured patients, poor patients, were unable to pay? When they come to the hospital, how can I give my time, my expertise, and my everything to be able to uphold justice for that particular patient? Now, another thing could be allotment of time for outpatient visits. So should it be equal time for every patient, or should it be based on the complexity of the case? Or at times, should it be based on social and or economic status? Now, here again, we have to repeatedly orient ourselves that patients with a particular amount of seriousness of the disease or whatever need to have time of the doctor. Now, we all know that doctors are in short supply in most of the hospitals. So time is precious. How do we spend that time? How are we punctual? No? Are we just in our duty times? And how much time do we really spend with a patient in trying to understand the patient, doing the necessary things? And at times, are these swayed by social or economic status of the patient? Now, at times we have violation of distributive justice also. Now, we know that medical representatives come and they give a lecture, and then sometimes they talk about kickbacks or paid conferences, so on and so forth, enticing us. And so slowly and gradually, at times, there are tendencies to write those medicines or investigations which may not be necessary. Now, we were discussing about an MRI for this irritable bowel syndrome. And it's not necessary. And then we're trying to tell the patient that it is not necessary. But at times, we see doctors writing a list of investigations and advising the patient to go to a particular scan center or whatever, because they get kickback. So when such things happen, we see that it's a violation. Now for a headache, most of the time it will be a simple one, but then if we think, oh, it could be some tumor in the brain, I should not miss it, then you will write a whole lot of tests and imaging so that you justify yourself, but actually it is not real justice to the patient. Okay, we also see in medical research, gross injustice do take place. To be ideal in medical research, justice is ensuring that the benefits and burdens of research are fairly distributed. What do I mean by this? Whenever we have research and we want to find out new scientific details, we try to get the data, and for that, we use human beings. First of all, we do other tests, animals, and then human beings, and then try to do the research. When research is done, to say, for example, if one medicine is better than the other, so then, there is a burden on the patient to take the medicine, to have the side effects if it is there, and so on and so forth. So many a times what happens is the burdens are laid on people in low socioeconomic countries, and then the benefits are obtained by those who can afford it. So vulnerable people are subjected to research. Most of the time in India, a whole lot of research has taken place where vulnerable people who do not know what research is, and there are times when they thought that that's a new type of treatment, and they felt that they're taken care of repeatedly, and they had no idea why their blood was taken. So they were put to some sort of burdens, harms, and so on, discomforts. And ultimately, whatever is found out that medicine is too expensive. Sometimes a country like India cannot have that. But then the research has been initiated elsewhere from other countries, and we become a prey to this. And because we are medically trained and we have the capacity to understand, we need to be careful when we do research, not to grab every research which comes on the way. And there are contract research officers, usually medical doctors, who play a great role in finding cases. And these very simple people who do not understand most of it will be trapped into this. So we need to be careful in medical research also and see whether justice is upheld. Now, when we think of the principle of justice in very simple, ordinary terms, it is caring for the weakest, marginalized members of our society, and to promote their welfare. So the important thing is promoting their welfare, promoting the welfare of the marginalized, the weak, the poor, the socioeconomically downtrodden. Now, how do we care for the weakest? So this principle is very important for us as healthcare professionals, no matter where we work, in a corporate situation or in government situation or in mission hospitals, wherever we are, caring for the weakest, we need to have a heart for that. And because only that will help us to be sensitive and to be gracious to such people, and not to burden them with burdensome tests and treatments which may not be useful. And so we need to be developing this in our own lives. So in a nutshell, we can say that the distribution of scarce health resources, which is not only equipment and things like that, it is human beings also, your time, my time, So scarce health resources and the decision of who gets what treatment, fairness and equality. These two things are important. And in research, the burdens and benefits of new or experimental treatments must be distributed equally among all groups in society. Now, is there any question? Okay, if not, I'll stop sharing this one and we can have some case studies. Case studies are really good because they help us to apply what we have, the principles that we have gone through, and some difficulty with this.
Ma'am, the upper part of this is not visible now. So can you zoom or scroll down? Scroll up.
Do you want me to share it, ma'am?
Is it visible now?
Yes, ma'am.
Okay. Okay. Now in the main group itself, we will go through the case studies one by one and see. So please unmute yourself and talk. You know, we are all adults. You have a lot of experience in yourself, and we are here to I'm here to facilitate, and collective learning takes place when we learn from one another. So please feel free to share, ask, and contribute. Right?
Madam, one request, is it possible to zoom a little bit, ma'am? Otherwise, the screen is very small for people using mobiles to read. The bottom right corner, you are having the zoom. Yeah, if you can just increase it. Thank you, ma'am. Thank you very much.
Okay. Okay. So I'll read this for you. A 80 years old male patient had acute pancreatitis with multi-organ dysfunction. In addition to other interventions, he was in need of ventilatory support as his breathing was rapid and his SpO2 was dropping. However, all the ventilators in that hospital were in use. This patient is well-to-do and is a relative of the local MLA, and the CEO of the hospital had called the ICU doctors to ensure that this patient gets the best treatment. There is a young patient with OP poisoning on one of the ventilators who is from a very poor family and will not be able to pay most of the bill. Okay. Now the question, I hope you have understood the scenario. I'm sure you've come across similar ones in your practice. It's quite often we are confronted with such things where wealthy patients come and you have the CEO there calling and telling. So you're obliged to look into that more keenly. But then, as we have been talking about justice issues, how do we handle this? Okay, what should be the parameters that govern how we prioritize care for patients? Can you please unmute and say? I'm sure all of us know these things. When we prioritize care, who should get more care, who should get ventilator, and so on, what should be the parameters?
Should be according to the need, ma'am.
Okay, very good. According to the need. When you say need, can you please explain?
Like the need for the ventilation in this patient. The other patient also has a need for the ventilation.
Yeah. So the patient, both the patients are serious and both
Yes.
of them are in need of the ventilator. Yeah.
Yes.
What else?
Outcome of the treatment, madam.
Very good. Outcome of the treatment. Yes.
Considering one patient as a very old, 80-year-old, maybe he may not improve. We do not know, but another is a young patient who needs who has got a life, and then to economically support his family. Other things you keep in mind, and that is one factor.
Yes. 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 Any more things?
As you mentioned, it should be free of market exchanges, like the other patient cannot afford and this patient is able to pay, but it should not be related accordingly of how much they can pay.
Okay, so you're saying that even if they cannot pay, that should not be a criteria.
We cannot deny the treatment because he cannot pay and the other patient is affordable and has an influence.
Correct. That is right. That is right. Now, just to counter this, I want to ask you or tell you, now this 80-year-old man, whoever it is, he's got acute pancreatitis. Now, as somebody said, we must see whether the outcome will be good. Now, pancreatitis is a difficult disease, isn't it? And so people who survive that at 80 years old, it is very rare. Okay. Now, because of want of time, I'm going further. Would it be ethically permissible to discontinue ventilation on the non-paying patient and give that ventilator to this new patient? Is it?
No, ma'am. No.
No.
It's ethically not permissible.
Okay. Now, what should the treating team do? In other words, there is pressure from the local MLA and the CEO, which is your SAO or director, and they are telling you, please, take care of this patient. It's very important. And for our hospital also. So what should the treating team do?
Any non-invasive ventilation or something like that can be tried on this other patient. the new patient.
Non-invasive ventilation. I'm not sure whether that is also available there, but that is an option. Yeah, good.
Other things can be explained to the local MLA and the CEO on the shortage of ventilators in this hospital.
And tell the MLA to send some more ventilators. Huh?
Ventilators.
That's one way of getting a ventilator for your hospital. Hmm?
Yes,
And what options can be offered to the family?
and they can be asked whether they can take him to another hospital for a
Referral.
referral.
Now, many
Referral.
of these places, there are no other hospital with such ventilator. Remote areas, no? If it
Ma'am,
is,
option about best supportive care or palliative care can be explained considering the age.
yes, yes, that is one option, isn't it? In pancreatitis, there will be severe pain, and this multi-organ dysfunction is a very bad condition, and age is there, and very soon it can be complete dysfunction or complete organ failure. So the prognosis of this can be explained to the family in a small meeting, and you can keep the CEO also there so that everybody is clear of what is said, and you could explain to the patient's relatives that actually this is a very difficult case. We will keep the patient comfortable and everything, and because of his age and the disease in itself, it is tough. So we highly recommend palliative care, and we'll do everything possible. Okay, my time is ticking by. Okay, we will go to the next another case study. There's no time for everyone. This is very common thing which you find in most of your hospitals. So I'll just read this, and I'm sure you'll pick it up soon. 11-year-old Dheeraj and his illiterate family live in a remote village in Uttar Pradesh. He has been ill for almost 2 months with cough and fever. His father took him to the local PHC many times, but he was simply given some IV fluids and cough syrups. As he was not getting better, the father also took him to a local doctor in a private clinics. There he was given some antibiotics and costly vitamins for pneumonia. No x-rays or sputum tests were advised. The father thought that after this expensive treatment, his son would be better. However, after a few days, Dheeraj became very listless and began talking irrelevantly, complaining of severe headache. Alarmed, the father wanted to take him to a bigger hospital in the city. However, he did not have enough money for the vehicle, so he took him in a borrowed motorcycle with another friend. After 2 hours of travel with great difficulty, holding an almost unconscious child on the motorcycle, they reached the hospital. There, he was asked to pay 5,000 advance to be admitted to the ICU, another 3,500 for a CT scan of the brain, in addition to the medicines, prescription, and payment for investigation that was handed to him. All this amounted to more money than he had brought after borrowing. When he expressed his inability to pay immediately, the angry doctor asked why he had brought his son to this hospital. You should go to a free government hospital, which is for poor people. Dheeraj was taken to the government hospital where there were no beds available for him immediately. A few days after lying in the corridor on a trolley, he died of disseminated TB with TB meningitis. Now, I'm sure many of you have come across such things, and it is a very pitiable stage that in our country, these are taking place. Now, what are the different levels of injustice in this scenario? Different levels of injustice in this scenario. Do you think it is injustice or it is okay?
It is injustice.
It is injustice. Why do we say that it is injustice?
Because the patient is denied of the treatment.
Correct. Yeah.
Whether
So
it is injustice or negligence, madam, on the part of the initial levels of care like PHC and the first private doctors who never did any other investigation like sputum and X-ray.
yes, yes, yes. Now all those are negligence. In one sense, when you say it is also injustice, no? What he should have got is a justice, but what he did not get, the treatment and appropriate investigations, is a form of injustice. Now, behind all this, there are other things, isn't it? There's illiteracy. Sorry? Come again? So please say, somebody was talking something.
Madam, you can continue, madam, please.
Yes. So we saw here that there is illiteracy and there is disempowerment. That means they don't have the agency or the power or the capacity to negotiate. And also, in that place, there have been no access to basic healthcare in rural areas. This is one common thing that we find. Even when sometimes there is a PHC or a CHC, there are no doctors, there is no electricity, there is no way of testing, nothing happens. So this is the reality. And no proper provision for transportation of sick people. And no proper roads. Sometimes these bumpy roads are terrible. And there are no other forms of transportation. And also we see that in government hospitals, there's overloaded with patients. And the very low spending of government money on hospitals and medical care. So there again, we see that it is not equipped or prepared to meet the needs of the crowds that come. Ultimately, we see that this patient was turned away by a hospital for lack of money, even for a child, that too for a treatable condition. No? TB is a treatable condition, and this is a child. It's not an 80-year-old man, but a small child. And then even for that, in spite of that, they've been turned out. That's very bad. Now, how can we as healthcare professionals respond to this injustice? Or is it only to government hospitals? Can somebody unmute yourself, please? Thank you. How can we as healthcare professionals respond to this injustice? Or do we think that this should be handled by government hospitals alone? What can we do?
There's a
yes. Yeah. Please go ahead.
There's a message in the chat which says the child should have been referred to the PHC to a higher referral government hospital if they had realized they cannot treat or have the required investigation.
Yeah, that's a very good point. They should have been referred. So, timely referrals to a higher center where this child could be treated. And of course, they need transportation. And yeah. See, when people are very poor, yes, please.
Even in private hospitals, now the central governments have got so many schemes. The Pradhan Mantri schemes and all are there, which take care of the poor people also in private hospitals.
Okay. Where such things work well, it is fine. And I've heard in some places the government doesn't, give the money in spite of the documents being submitted, and people in the private thing lose interest in utilizing such government facilities. But these are all good things. For that also, if you are educated, if you can argue, if you can tell, these things, then the response is good in our country. But if you're an illiterate poor person who cannot talk, then people just leave you. That's a plight. Now, in such a situation, what can you and I do? That's the important thing for us today. No, you and I, by God's grace, are educated people. And yes. I say by the plight of our country men and women, and advocate for their rights. So that is important. So wherever possible, whenever possible, do our best personally to be involved in the care of the poor in various ways. And we should not ignore them or forget them. Whenever at our hospital doors, when poor people come, be a little more gracious, talk to them in a way that they understand, guide them, help them, and enable them to get the needed help.
Hello, ma'am.
Finally, we just look at this. How could the hospital create systems to include the poor in their circle of care? What can the hospital do? Yes.
Ma'am, have a strong community awareness, involvement in the community by conducting routine camps and screening camps, and also strong home care facility as well will help.
Okay. Another thing is, being involved in schools. So if you teach the students, there is a wide permeation of whatever awareness things we are teaching. And that is another thing that you can keep in mind.
Ma'am, we can have liaising institutions or NGOs which can liaison between the communities and government.
Very good.
So
Okay.
there are secular NGOs like that who are, but they are secular. I don't know about any Christian NGOs doing this in health sector.
Yeah. Yeah. So wherever possible, we can network with others, like-minded people for that particular activity. So healthcare of people. Now, we may not agree with all their philosophy. That is okay. But in areas where we can network with people, do that so that we can penetrate into the communities and uplift the poor. And try to come to a provisional diagnosis without, writing battery of tests, investigations, and treat people with dignity. That is another important thing which you can give. It is free of cost. It's our attitude, how we deal with patients, whether we give time to them. Listen, just listen. And, when I did medicine, we've been asked to listen, palpate, percuss, auscultate. In other words, find with your own senses what the real problem is and take a proper history. Many times all these things are not present these days. And so in your particular hospital, if it's a mission hospital or your personal hospital, have policies that you will never turn away patients because they cannot pay. But then how will that payment be done? Try to have some funds, not big funds, but small funds. And many times even the hospital staff have wonderful ideas. You ask them, how do we help the poor patients? I know a hospital, a small mission hospital, where the hospital staff provide early morning, bed coffee or tea and some biscuits to all the patients in the ward. So small acts like that will help. So that will kindle an atmosphere in which you inculcate that quality in you so that you can be efficient in your own practice. Now, just a minute, I would like to conclude with the last slide, which has gone missing now. Okay, so in conclusion, I just want to say that justice is one of the 4 principles which lies at the core of moral reasoning. So this should be in our mind, moral reasoning. For that, to say what is good, bad, right, wrong, wise and virtues, we need this principle of justice. And of the several categories of justice, the one that is most pertinent to clinical ethics is distributive justice. And this refers to fair, equitable, and appropriate distribution of healthcare resources determined by justified norms. Now, justice is a value that must be upheld not only in the treatment of individuals, but also in aiming for the removal of inequalities that exist in reasonable healthcare access for entire population. In other words, we have to work towards populations in communities to be able to access reasonable healthcare. And as healthcare professionals in India, it is imperative to have a vision of justice in healthcare access for the people of our country, especially for the poor, the vulnerable, and the marginalized. So we need to keep that in our minds, or write it and put it in your room. You know, the justice as an important core principle, which is highly valued in the Bible, that we inculcate that, and that becomes part of you and me. And of course, in medical research, justice is ensuring that the benefits and burdens of research are fairly distributed. There's no time to talk about standard of care, post-trial benefits, and so on. But anyway, the burdens and the benefits of research should be equally distributed among the different sections of society. So I've come to the end of this presentation. And if anybody wants to contact me, the details are here. Thank you.
Thank you, ma'am, for sharing various aspects of justice and healthcare, and also how to treat patients equally with the interactive case studies. Next, we'll go on to the next session by Dr. Priya John ma'am. Now, Dr. Priya John ma'am has worked in various in a mission hospital as well as taught in a medical college. She has done her post-graduation in community medicine and also diploma in the National Board in Social and Preventive Medicine. She has done a course in palliative medicine and worked in a hospice in Delhi. She is now the General Secretary of Christian Medical Association of India. She's married to Dr. Sweeraj John, who's a surgeon and blessed with a son named Arthur. We're very happy to have you.
Thank you, Elizabeth. And thank you to both EMFI, Dr. Sukumar, as well as TCB, Dr. Rupa Verghese, for including me in this. My only claim to fame when it comes to bioethics is that as CMAI, as Christian Medical Association of India, we were one of the founding members of the Center for Bioethics. And Dr. Jamila George is the one who just put all the foundations in place. And that's how I'm here. And also because I attended the ICMDA bioethics training, which is from Professor Dr. John Wyatt. So this is my claim to fame, and that's why I'm here. But as an organization, we, as a Christian, as part of a Christian healthcare network, we understand the importance of having an organization like the Center for Bioethics, and as Dr. Jamila has ensured, the availability of ethicists in our country, because there is no right or wrong answer for when it comes to bioethics. There are difficult questions with equally different or difficult answers. But what is our basis for making those decisions? What is it that we believe in? What is it that we stand for when we make these difficult decisions and when we have these difficult conversations? So my topic for today is the last of the principles of bioethics, which is non-malfeasance. We talked about autonomy, we talked about beneficence, social justice, and now it is non-malfeasance. So I'm just going to quickly share my screen. I have a presentation, but also trying to understand what is the requirement of this session. I understand that, is my screen visible?
Yes.
Okay. And why did EMFI and TCB decide to do this kind of a virtual conference on bioethics? I think it's very important that all of us, as a community of healthcare professionals who are wanting to do the right thing, we all are somewhere on the same page when it comes to a very different and changing world views and our own alignment to what our faith teaches us. So coming to in this principle of non-malfeasance, I understand I have exactly half an hour or less to speak. So the few things that I need all of us to go back home with is, what are the definitions we're talking about when it comes to non-malfeasance? What is the understanding of harm? And are there some laws that protect the patient as well as the medical caregiver? Because in trying to keep up with this principle of non-malfeasance, you as a healthcare giver as well as the patient both need to be protected. And are there laws which do that? Definitions. So non-malfeasance is the principle, the fourth principle, used to communicate the obligation to do no harm. We will not do harm. Finished. Now, we talked, Dr. Sati spoke about beneficence. And somewhere beneficence and malfeasance are two sides of the same coin. So it was very difficult sometimes to make a distinction. There were two aestheticists who came up with some kind of a distinction between these two faces of the same coin. So they said that non-malfeasance is the maxim or the norm that one ought not to inflict evil or harm. Whereas beneficence includes the following three norms. You have to prevent evil or harm, you have to remove evil or harm, and you ought to promote good. So beneficence is a little easier to follow. But it's interesting that here they're using the word evil or harm. You know, there are so many definitions of what is evil. And but let us talk here about the aspect of harm. Now, harm can be defined, or how do we understand what is harm? Is it harm only to the patient? Is it harm to the relatives who will be left with that emptiness or the guilt or the what if I had done, or what if I had chosen differently? That conflict of whether they made the right decision. What harm are we talking about? Now, the clarity here when it comes to non-malfeasance, and as medical healthcare professionals, it is always related to the harm that you might inflict on the patient. Even that is subject to different worldviews. For example, in our bioethics training under ICMDA, a child who was 2 years old had a near drowning accident and was put on a ventilator at 2 years of age and was still on the ventilator when he was 14 years of age. Now, in all fairness of the principle of non-malfeasance, it would have been correct, ethically or correct to maybe disconnect the ventilator after a certain time. But according to their belief, their faith, the relative said, if you do that and you take away his ability to naturally die, he will not go and meet his creator. That was the belief. So the harm is not regarding only the physical or the status of the patient, but it is also related to religious, to spiritual beliefs, and to ensuring that the family does not go away with a big pot of guilt or an eternal conflict that they have to deal with. Now, that is not an easy decision-making process, despite all the principles that we might have. Going to the next. It's not moving. Has it moved? Okay. Can you see the next slide?
Yes, ma'am.
Okay. Now, again, keeping all this in mind, the conflict, the guilt, the harm, who are you doing it to, etc. Again, Beauchamp and Childress in 2013 came up with some issues and concepts associated with the principle of non-malfeasance, what we are talking about. So on one side, they said, we must uphold standards of due care. We must, and the second point, negligence is the absence of due care. That means you're choosing or you're not giving the due care allowed to the patient or due to the patient, and you are imposing either a risk of harm or an unintended careless risk of harm or an intentional reckless risk of harm. All very, they're using words that cover everything. And third point on the left side, making distinctions of rules of rules that govern non-treatment and end-of-life decisions. Sorry about the typo there. So these are 3 points which I would discuss again in the next slide. But on the right, we have 5 points. And this is where I will bring a distinction when I talk about in the next slide. So you have withholding and withdrawing life-sustaining treatment. We have either a choice to do heroic or extraordinary and ordinary treatment. We have sustenance technologies and medical treatments. We have intended effects and merely foreseen effects, which is called the double effect, which we will talk about in the next slide. And we have killing and the letting die concept. On one side, point number 1, 2, 3 are usually seen in a kind of critical care setting, in an ICU. You're trying your best to give the due care We're trying to bring down all the risks possible so that you do not cause any harm. And you're also trying to make distinctions and rules which govern non-treatment and end-of-life decisions. And this end-of-life decisions move us to this side, the ABCD, the 5 points, where you start withholding, withdrawing. You start, maybe thinking about whether you should do heroic, extraordinary kind of treatment or just do something that sustains. We're thinking about double effect. But E is something that we're definitely not thinking about. Okay, but we are considering it in the light of these concepts that are always associated with the principle of non-malfeasance. So looking again at the first 3 points, which I've kind of merged. So when you say upholding standards of due care, you're trying to do the best practice, the due care standards, which are adopted by professional organizations and regulatory agencies to minimize harm to patient. Okay, we're talking about minimizing. We're talking about doing what we can do best in that situation. The second point, regulatory agencies. Now, this is the important part because this is where the laws come into play. They develop oversight procedures to ensure that healthcare providers maintain the competence and skills needed to properly care for patients. Even if you are choosing to, you're not able, I'm not saying you're choosing, you are not able to do good and, go 100% into some kind of heroic treatment, but you are still maintaining the competence and the skills which are needed for the proper care of the patient. Negligence. Now, under this big word, okay, non-malfeasance has a wide scope of implications in healthcare, including this need to do away or to stop this whole idea that this is negligent care. Oh, you're not doing this, you're withholding, you're withdrawing. So should not come under the ambit of negligent care. So the need to avoid harm when deciding whether to provide treatment or to withhold it or to withdraw it, and considerations about rendering extraordinary or heroic treatment. Now, this is all a part of the decision-making process, which again is not an easy one. And it should not be left to just the individual to take that very difficult decision. And we'll come to what we can do, and that is where the laws come into play. Clinical judgments usually are made in the face of uncertainty, even though the medical probabilities are fairly clear. Many times through the various studies and through the, the multicentric studies and the data that we have, there is some fair clarity about what the medical outcome or the probabilities can be for any given situation where there is a terminal illness. So Johnson et al. Says that clinical judgments are usually made in the face of uncertainty, despite the data available. Okay, again, not easy situations. Before we go to the laws, need to talk about what is this double effect. Performing some, we're talking about, probably a critical care situation. Okay, you're in ICU, you're trying to make decisions. But on the other side, you're also looking at end of life care, where you are still trying to provide due care following standards so that there is proper care given to the patient. So you're performing some actions which may have two potential outcomes. One is the good intended outcome. But the other one, in order to get that good outcome, there might be a second, less acceptable outcome, which also might be foreseen to occur. And the most common example of that is the use of morphine, where you have it being used specifically for prayer as for pain as per the WHO pain ladder, but it also causes some depression in the respiration. So how do you balance these things? So in all these situations, there has to be a balancing of actions according to their good intended effects as compared to their possible harmful or adverse effects. That data, that analysis, as per the patient, needs to be discussed, needs to be thrashed out before you make a decision to go ahead with a certain treatment. Now, in the American Nurses Association in 2015, there was a quote which says the nurse should provide interventions to relieve pain and other symptoms in the dying patient consistent with palliative care practice standards and may not act with the sole intent to end life. The word intent is very, very important. The terms killing and letting die raises issues of legality, ethics, homicide, suicide, euthanasia, acts of commission and omission, and other active, passive distinctions. Now, when a country legalizes some of these things, it becomes an easier point to keep bolded on the PPT where you say killing and letting die. But here, in our practice of bioethics, this is something we take seriously and we do not consider it as a legal action on any front. Again, after the double effect, this is another thing which you just need to know a little bit about, a slippery slope. And it always comes to, putting a patient on a ventilator, then deciding whether to take the patient off the ventilator. So these kind of, I want to read the whole thing. This is there, the PPT will be shared. But it is a situation again where there is a primary event is being discussed or practiced. But in the timeline, there might be a hypothetical slip toward a more morally unacceptable situation. So when we look at practice of bioethics, we're trying to ensure that all undergraduates, postgraduates, and practicing consultants and everyone has a clear understanding of what is the correct documentation process, what are the correct rules and policies of the institution itself against what is allowed by the law of the land. So these things are important. And the example of a slippery slope, apart from the usual ventilator one, put it on, put it off, is about the legalization of physician-assisted suicide. So this was done by the Oregon Death with Dignity Act. So the proponents of this act said that, allowing physician-assisted suicide, which involves a patient's voluntary decision and self-administration of legal drugs, may or may not in itself be morally wrong. And because of this, the proponents, they passed this act in 1997. And they're saying, see, as of 2014, so many years down, there has been no, 17 years down, there has been no slide towards legalization of non-voluntary euthanasia, where a person was, just because the law is there, the act is there, they're trying to push a person who doesn't want euthanasia into that. But that's not happened in 17 years. So the proponents saying, what's wrong with this? But opponents believe that people proposing this type of argument mistreats people's abilities to make definitive distinctions between moral legal, immoral illegal issues, and to exercise appropriate societal controls. So slippery slope, double effect, and of course, the other things about negligence and what is due care. Now, what are the laws? In our country, there was a bill that came out, and Dr. Jamila at that time was the executive director of the TCB, and all of us as founding institution and members of the Center for Bioethics, we received this bill because as per procedure in our country, when a bill is formulated, it is sent out to the public for inputs, and then those inputs are compiled, and then it goes to the houses to pass it as an act. Now that is the procedure. And then it becomes, after it is passed in the houses, it becomes an act, and then the rules and the regulations are set. So this bill came out in 2016, and all of us as a Christian healthcare network and beyond, we gave comments against each part of that bill. And this bill was called the Medical Treatment of Terminally Ill Patients, Protection of Patients and the Medical Practitioners Bill. Now, to my knowledge, this has not become an act, okay? But there have been a lot of, feedback and talks and studies and, experience sharing as to how we can make some legal procedures to protect the patient as well as the medical practitioners. So I'm going to quickly go to the next slide, which shows a flow chart. The flow chart is coming on the next slide, but this is taken from the Indian Journal of Critical Care Medicine, and it was published last year in May. So this is a simplified legal procedure for end-of-life decisions in India. And interestingly enough, this was done by two opposite groups on the spectrum, the critical care physicians and the end-of-life task force in our country. So what did they come up with? They came up with this kind of a flow chart. Again, I will not go into big details, but it's just here as a suggestion for all of us to be part of a legal procedure which will protect us from any kind of legal action either for us as caring physicians or doing harm to the patient. So here we're looking at life-sustaining treatment. We're looking at a primary medical board at the hospital level, which is, they have a composition which has been laid out, and they take a decision, a collective decision, whether we should continue life-sustaining treatment. And then all this is done in the span of maybe 4 days, okay? So treatment team is informing the patient's next of kin and anyone mentioned in the advanced medical directive. Now that's another thing which is also called the living will, okay? Or now the proper term is advanced medical directive. If the patient when they were in the right mind when they were able to, they made a kind of a directive if this ever, in their life, this kind of a situation arose where they had to make these very difficult decisions. And who was the family mentioned in that? AMD. Now, it doesn't stop there. It goes within 2 days. Again, it goes to a secondary medical board. So this is something that is outside the hospital, okay? And then that board reviews it, and within 2 days, they come back with their decision, which can be yes or it can be a no. And if it is a no, the family or the treating team can go to the High Court. If it is a yes, they just implement the decision, but they have to record it at the judicial magistrate. So this whole thing about non-malfeasance, where you're withholding, you're withdrawing, and you are, choosing to do no harm, okay? All that you are covered under these legal procedures. So this is a flowchart as of now, which is available. So again, coming back to why we are doing this virtual conference in bioethics, is to appreciate the ethical dimensions of patient care Because when you hear the last session by Dr. Santosh, you will hear there are so many dimensions to patient care. There are so many, the ethical principles of medical profession. To have competence in core ethical and behavioral skills. Okay, that is what you have to do. Informed consent, what is the procedures of your institution, etc. And to know the commonly encountered ethical issues in general and in one specialty, and to have competence in analyzing and resolving ethical issues. And the last point is to appreciate cultural diversity and its impact on ethics. Again, you will hear it in the closing session. So just to end my talk, the next slide. The last one is there are values, in most of the documents that you read about the principles of bioethics, it always says it should come under the principle. But here I am giving you I'm saying there is a different way to look at it. You are building. Okay? First, you have a sense of values. The sense of values can be moral, which is a secular set of moral values, or it can be Christian values, okay, which are very clear as per, I think Dr. Ashita also mentioned it about what is fitting into what the good Lord is expecting of us. So you have guiding principles. It can be the four they are the four that we've talked about, but they're also something more to that based on our Christian belief. And then you build on it by understanding the practical implications of bioethics. That's what we're trying to do here. We have case studies, we have various questions related to the same. Then you develop an ethical code of conduct for your own institutions with a checklist. And then you promote your own self-declaration and ethical code of conduct. What is it? What is the oath that you took? What is your own belief system? How do you implement it when you have a value that you hold on to? How do you showcase it in your everyday practice? Fellowship and discussion program for forums. Very important to have forums where you can talk about it. And that gives you a cover because you're looked at as an ethical healthcare professional. You could be a nurse, you could be a doctor, you could be an allied health professional, you could be a chaplain, you could be a hospital administrator. Whatever your role is, that is, you're looked at where you're covered, and because this whole structure is in place. But the challenge for each one of us is, are we doing it because we have a title before our names that we will, and we follow a strict code of conduct? But is it because we are looking at the one person who taught us that we are the Christian presence in a hurting world? And in the face of that, we can do no harm to anyone, and we will always strive to do good, keeping in mind the compassion of the cross, the love of the cross for everyone, and the beauty that comes from just having the shadow of the cross on all of us. And that is what we need to really strive to become. So thank you. I hope I haven't taken too much time. Thank you, Elizabeth. Should I go over to you, or do you want to have any questions?
If there are any questions, we can post in the chat box and we can take it up now. Am I audible?
Can't hear you, Elizabeth.
If there are any questions, maybe they can post it in the chat box and you can take it.
Okay. Thank you. Elizabeth, I think I'll hand over back to you. Thank you.
Thank you so much, ma'am. So the next session we'll have with Dr. Rupa Varghese, ma'am. She has done her MBBS and MS in obstetrics and gynecology from CMC Ludhiana, diploma in emergency obstetrics care from Karolinska Institute, MA in bioethics from Trinity International University. Rupa ma'am is presently working in Chhatarpur Christian Hospital, Madhya Pradesh. She is also a qualified bioethicist and she heads the Center of Bioethics India. She has written, published, and spoken on various platforms on topics of women health advocacy, reproductive health, and rights. We are very happy to have you here, ma'am. Okay.
Thank you, Elizabeth, and thank you, each one of you to be here today, because it is not just an opportunity but a privilege for me to be sitting here and speaking, and also having this platform like a lot of us shared before, including Dr. Jamila. This has been a dream for many years, 12 years into instituting this the Center for Bioethics, and we've been waiting to have an opportunity to have a meeting and a session like this. And I really thank EMFI for providing this platform to the Center for Bioethics and helping in all the organization and everything that was associated with it. Just to like pour out my heart in that way, saying that even though it's a privilege to be here, but also it saddens a little bit, because when we were trying to arrange this conference, there was there were like sessions where we were kind of thinking what exactly to do in bioethics. And in spite of this, in spite of bioethics being in a center for medicine from, I think, so many years before, we in India still so lagging and so behind still in our knowledge of bioethics. And that definitely saddens us, because it's something that needs to be inculcated in our day-to-day settings. It needs to be known, it needs to be understood, and still we lack the knowledge and the understanding. We know some part of it, but how to implement it, how to go about using it in our daily day-to-day activities is something that we realize that we are still way behind in understanding bioethics. And that was the intention behind doing this for one of its kind virtual conference. This is just on bioethics, and this time we deliberately chose topics which were just basic, meaning coming to the bottom line of understanding what makes the core of bioethics. And I think each of the speaker before has done a really wonderful job in explaining the minute details of the basics of bioethics, the principles of bioethics. And my job right now, or my specific time right now, would be to kind of get this all into a more practical approach before we go into the plenary, which would be how to look and view all these things in a Christian perspective. But before we go into understanding the Christian perspective of it, we also need to know the law of the land. We also need to know what exactly goes around in the practical circles, and how all these basic principles, when we are put into a situation, you've realized that how you need to imply into a situation, but what exactly is the law of the land, and what is it that like what is it that we are expected to do if we are faced with a situation? What are our duties towards our patients? What are the duties towards our fellow colleagues? So that is something that I would be sharing in my topic, which is medical ethics and law. So without further ado, if I can go ahead. So ethics and medical ethics, I think for the last 3 hours, we've been discussing the different virtues of medical ethics. And just to simplify understanding, so ethics is something that we use on our day-to-day, every activity in our day-to-day life, which signifies our moral values. But when it comes to medical ethics, we are more dealing with the moral principles, which we require for register. It's for medical practitioners in dealing with each other, with their patients, and especially, like I said, the state or the law of the land. Till 1956 is when the Medical Council of India was established, and till about 2019, it was the Medical Council of India which dealt with the medical laws and ethics of India. In 2019, there was a transition and it changed into the National Medical Council. And today is NMC, or the National Medical Council, is what deals with the laws in medical, and not just in medical ethics, but the entire medical fraternity is governed under the National Medical Council. It was fully established by the year 2020. So what exactly constitutes this medical etiquettes? Now, like I said, you have your responsibilities towards your patients, definitely, and that is what we've been discussing all this. But we also are a really privileged and we are a really honored community. We are people who are looked up because we ought to make life and death decisions for individuals. People who cannot exercise their autonomy, people who don't understand what is good for them. We try to tell them what is best for them through the knowledge that we have acquired. And if in case we cannot exercise that knowledge, and if in case we are not able, we go into issues where we end up having malpractice or we end up having negligence, there is definitely something called as a medical register, where all of our degrees are registered into, and each state governs it individually, and as well as the National Medical Council governs it centrally. So if you are caught doing any sort of negligence or malpractice, it is the first level is a disciplinary control, which is done by the State Medical Council. It then is further passed on to a warning notice, which is done in coordination with the National Medical Council. And if we go even beyond it, because there are individuals who, especially in cases of malpractice, or there are certain entities in medical field which are unpardonable. A few of them would be the provisions which come under the Organ Transplant Act or the PCPNDT Act. These are laws which I'm not sure if everybody is aware of it, but if there are graduates in this group who may not have heard about it, the PCPNDT Act is something to deal with the ultrasound guidelines that a doctor can do. So you are in India, you're not allowed to determine the sex of the fetus, and anything that you go beyond this law can be, it is considered as a criminal offense. Same is with organ transplantation. So there is a lot, because there is a lot of nexus and a lot of vulnerable groups in India, due to which the Organ Transplantation Act is something which is really really strict. So anything dealing with that sometimes straight away goes into criminal malpractice. And if caught with, you can straight away go into a professional death of your medical services, which is taken care straight away by the National Medical Council. Coming on to our duties towards our medical practitioner has towards one's patient. So like we have been discussing in the various case studies that we were given. So the moment you are in contact with your patient, you are bound to you have an understanding with this patient, and that so most of my the things that I'm going to discuss, you've already taken the principles behind it, but how do we imply, how do we put it into practices? So it's kind of a contract that you are forming between yourself and the patient, that is the treating person and the patient, and it's an implied contract which says that Again, you would do the best of what you know, you would do the best of your ability, and you would not do any harm in treating that patient. That is your implied contract. You will provide the duty towards the person who is sick, like I said, to do the best of what you know. Also, in continuing the treatment, let's say the patient, this is just for an example, this is not a direct thing, but let's say the patient wants another person, he wants to contact another person, like, or Dr. Ashita was saying that the person is actually wants to rely on a quack or wants to rely on a Baba to take his or her decision. In such events, even in such case, okay, how and what can we do to the best? Because sometimes making a person understand, or a patient understand, is a very difficult proposition, and it's not so practical. Even in those cases, sometimes even if they walk out from our place of treatment, we need to keep our doors open. We need to still continue treatment. And that can be done with the fourth point, which is earning confidence. And earning confidence comes from the skill, absolutely the skill that we have, and also in how we interact with the person and how we interact with that patient who's in front of us. So many a times, you would have heard the saying where the patient says that having a conversation with this so and so doctor took half of my treatment away. So that is a very valid and a very genuine point, because understanding or giving that shoulder to be on for that patient is a very important decision making, or a very important criteria for a medical practitioner towards his or her patient. Also, in cases of children or patients who are infirm, like they can't make a decision, or mentally challenged patients, our challenge increases furthermore, because you know very well that this individual in front of you, first, is scared, second, cannot take his or own decision, third, doesn't know actually what is happening with him, whether it is decision making for treatment, whether it is even asking the person to take a tablet. It's more or less going to be a forced thing. Because, for example, for a child, you may take the right decision. The parents might be totally in rhyme with what decision you have taken for the child. But in the end, the child is going to be forced with that medication. So it's still very much important for the doctor to make an effort to coordinate and to communicate with this patient in front of him, which may be a child, to make him understand as that what is best for this child and what exactly it is. It takes time, it takes patience, but yes, it is also a part of our duty. Then we come in a category called as people who need to really maintain professional secrecy. And we also are individuals who are privileged to have communication, which you may be the only individual in this world to whom this communication may be done. So a professional secrecy, we are entitled to know so many details about an individual, which the individual may not be comfortable sharing with anybody else in the world, even his or own life partner. So this professional secrecy needs to be maintained at utmost cost. And it is not only a duty, but also a law to maintain the secrecy, unless in certain situations, which I would go forward and explain. Same is with privileged communication. So what are these privileged communications that we are talking about? Privileged communications come in cases of infectious diseases. Then they come infectious diseases. You may put, just for easy understanding, you may put it as patients who may have hepatitis B or HIV, or any other venereal diseases like having syphilis or gonorrhea. These are diseases which an individual may not be, even in today's date, even having COVID is sometimes not something which individuals are comfortable sharing with, or even tuberculosis in a good environment, in a modern society, is not something which is shared with or openly shared with. It's taken as as a lot of secrecy. So but we happen to be, or we physicians happen to be individuals who know about the patient, who know that this patient is suffering from this condition or not. An employee and an employee's relationship. So we might be people who to whom different the employees may be coming for an annual health checkup, or even just for a normal checkup, and we may end up in knowing certain problems with this person has. It is our duty to explain to the individual what problem the person has. For example, let's say take an example of a driver who comes for an annual health checkup and ends up and we come to know that he has a vision problem, or he has a short sight. So it is a privileged communication to know that this is it. But being a driver, it is also our responsibility to make this person understand that it will be difficult for this individual to continue with his professional work. Yes, it may seem as very strong, hard decision, and it may also affect the work condition of this individual. But yes, that is also a part of our responsibility. So our responsibility also comes in making the person understand what exactly, or how much exactly is the person affected, and how he's affected, how he can actually get it treated, or is there an option for treatment, or does he need really help, and will he put the other person's life in danger because he's a driver. So obviously he'll be carrying people or taking people in his vehicle. So would he put this person's life in danger if in case he continues driving? So there are eye conditions like refraction which can be corrected by just glasses. But then there are conditions like glaucoma, etc. I'm just giving a simple example which the person may not be, it might not be easy just by doing a refraction. So that is also a privileged communication. So dealing with such cases is sometimes very difficult and very confusing. Notifiable diseases. So like, for example, the easiest one would be COVID. So there are other conditions like tuberculosis, again, venereal diseases, etc., which are also notifiable. Okay, so and it is our responsibility as doctors, even if we are working in a private health sector, even we are working in a private clinic, it is our responsibility to notify it to the government if there is a suspected crime. Now, when I say suspected crime, again, I put it into emphasis. We are not left alone if we say that this is a rule for the government medical colleges or the government hospitals. No, any individual, even if they are working on an outpatient department, we are medically and lawfully, we are required to, if we are doubtful that there is any foul play associated with this individual coming to you. So one of the weirdest examples that I could give is a person coming to a dermatologist asking for treatment for some marks or some discoloration on the skin, and the dermatologist suspects it to be either maybe a suicide attempt, or maybe some bruises which may be caused due to marital injury, due to some assault. Forget marital injury, but due to some assault. And even in those cases, it is the responsibility of a dermatologist who might be working in an outpatient department to notify it to the required person. And how we notify it is with something called as an MLC. An MLC is different from an FIR. An FIR is a first information report, but an MLC is just a notification to your local police authority saying that you suspect that there is something wrong with this individual, something wrong has happened with this individual, and it would be nice for you to come and inspect it. And you would have to give your reasonings as to why you do it. Because we always think that it is only during sexual assault. Many of us think that it is only during sexual assault or road traffic accidents that this may come into play. But no, even for simple things, on a day-to-day basis, a suspected crime can be has to be reported. For patient's own interest, for example, even if it is an HIV positive patient, the patient needs to go and work in a health sector. How and what can the patient do? How much can a patient work into? So it is not always necessary that an HIV patient will always be an infected patient. So how much can he work with, what all can he deal with? Does he come directly under directly come under treating or on indirect patient care? So these are things which as a doctor we may come to know, but how we are also privileged to understand, we know the information, but we are also responsible for how much of this information can we let go, or can be shared. In the court of law, definitely in the court of law, when we are asked a question, we need to limit ourselves with the understanding that we have. So in the court of law, most of the questions are directly asked onto us. Like there are direct questions. So it is better as medical professionals to stick to what is asked for and not go beyond what is asked for. So if you're asked a question that when and where and how, or when was this incident, or how was this incident, so you stick to the point of how and when this incident or may have occurred, instead of going and tell or disclosing every information that you may have known about that individual or that incident. Duty of a medical practitioner towards the state, again, it also includes, like I admitted before, notification of infectious diseases, notification to the police, notification of birth and deaths. So 7 days to 14 days is the time that has been given to each individual to notify the fact of birth and deaths that happen under their supervision. Also, issuing of certificates. Issuing of certificates is something which is very is something which as medical practitioners or graduates who are going to who are going to be medical practitioners very soon, you would realize the fact that it's something which is asked very commonly. And it's very difficult for us sometimes to, if it's, you need to really be sure about the fact that how long and to whom can you issue these certificates. For any leave that, or any permissible leave that you are going to grant to a patient who's been asked, you need to know the full details. Without examining the person and without proper documentation, you cannot allow, or you cannot you cannot put in those you cannot sign in for a certificate. And if you cannot also give in a certificate for longer period of times unless it is specified, like for example, maternity leave, the certification for a maternity leave, you have a certain period of time which is already sanctioned by the government or the system. Except in those cases, no other leave can be sanctioned for more than 15 days, because you're actually required to bring the person again, examine it, and then further proceed in giving leaves if and as and when required. So issuing of certificates is something where malpractice, where issuing of bribe or fee splitting, so many things happen just because of the fact that they are the most bribable conditions in which medical practitioners are caught in. So that is one of our duties towards the state. Also responding to medical emergency, not just in military services, even though I wrote military services, but even in normal situations. Like for example, the easiest or the most recent one to understand would be the COVID conditions. So being individuals who are working in private healthcare sectors, other than government sectors, we still are responsible if we are called for help from a private sector to go and help individuals to go and help the government if in case they are required. So if the load in a government hospital increases, we still need to be obligatory to the fact towards the state if help is acquired of us. Going on for the duties of a medical practitioner towards one another. Now, this can vary from person to person, but some things are just obligatory. It would be nice and it would be respectful to extend the same honor and respect and a good behavior when you're dealing with another colleague. He or she may be your known colleague, or maybe somebody that may have been referred to you. But as a part of a respect, when you deal with other medical practitioners, it is good to give them respect and honor. And many a times we may be approached by patients to get a second opinion or a third opinion or just an opinion. It's always, even if you know that the person before you may not have done a good job, may have done something which should not have been done, but it is better not to utter anything which may pull them down, especially to bring them down, because it's a very normal human thing to say, oh, what was done was wrong and it should not have been. But you could place it in a different way, or respectfully deny the fact that I'm not sure why he took that decision, but in my opinion, this is what I would be doing, or this is what I would suggest you to do for this disease condition. Again, if you're in a really corporate sector and there's a really cutthroat competition going on between dealing with individuals, it is not good, and it is not ethically and morally right also to entice patient away from your colleagues. Patients should understand, and patients should come to you with the understanding of the fact of what you do, what your medical practice is about, not because you entice them by either bribing them or by luring them into due to various there are so many ways of enticing patients, or advertisements, etc. So as a doctor also, we are not supposed to advertise the features that we are in. So the patients are supposed to understand and know our skills, which is evident through the work which we may have done to the different patients that we may have treated before. And that is how patients need to come to us, not with we propagating in what we have been doing. Same as the fourth point is something, like I said, it's not mandatory, but if possible, a lot of places do oblige other medical practitioners to have a free medical service, just as a mark of respect to each other. It's not something which is compulsory. It is not something laid by the state, but it is just something complimentary that you do. Also, in an era of social media, it is better to refrain ourselves from propagating various diseases or disease conditions just for the sake of making the world understand that we have been doing such a fabulous job of treating conditions which the world may not be comfortable, or which the world may not be knowing. So all this comes under creating an environment which is not harmful for the patients to know. Coming on to professional misconduct, which is what the first thing I said, the state body may pick you up in various conditions if it comes into their knowledge. And one of the most common ones, the conduct or which are disgraceful or dishonorable for the medical professional, and can be a problem in the competency, would be again, like I explained earlier, issuing of false medical certificates, even covering up for unqualified people. So it can happen in any sector, whether it be in the government medical sector or in a private sector, where you may have people who might be referring patients to you, but they actually are not qualified. They actually are not qualified even to see those patients. And if we are vouching for them, if we are actually supporting them, we are actually creating an environment of professional misconduct. Same is with helping quacks who are actually not medical professionals, but people who claim as medical professionals. And we may claim that their knowledge about it is and their knowledge about the medical profession is quite good. Their hands are quite good, because there are a lot of people. One of the commonest examples would be people who work with surgeons or orthopedicians who claim to be there's something called as compounders, etc., if you've ever heard about it. And they do a very good job because they've been placed with doctors, and they've been doing this job for a lot many years. But you cannot qualify them as medical professionals. Okay, sometimes their diagnosis or their way of picking up things may be much better than the doctor itself, but still they cannot be qualified as medical professionals. So we cannot be canvassing for, we cannot be supporting them or canvassing for them. Same as would be advertising and canvassing. Again, I shared it, like I shared before, as doctors, we cannot advertise ourselves. As doctors, we cannot, we are not allowed to put in our banners or posters saying that or claiming that this is what we do. It is on the onus is on the patient who has been treated before with the skills that we have to take forward or be our canvassing agent, not us professionally. That is not something which is allowed. A lot of people may have realized that to open a chemist shop is something which is done very commonly in a lot of places, not just it's irrespective of south or north or east. It's basically you give your registration to open it. So basically you start a small clinic sort of a setting, and then you give a pharmacist a license to open a drug shop, saying that this is attached to this clinic as a part of a business which you have. So that is something which is illegal. That is something which is considered as a professional misconduct. To prescribe habit-forming drugs, there are a lot of habit-forming drugs. One of the simplest one would be prescribing cough syrup for somebody who really doesn't require a cough syrup. There are places and there are people who have been picked up for simple simple things like cough syrup being prescribed for just basic addictions or basic sleep prescribing drugs. So this is just one of the examples, but there are so many other drugs, even painkillers, or even sometimes even morphine as in a palliative care setting. So there are so many drugs that can be habit forming, and to prescribe these drugs in an irrational way is also considered as a professional misconduct. Again, disclosing the professional secrets of patients. So during our conversations with the patients, so again, we like I mentioned before, we are people who have professional. We need to continue the professional secrecy that we have been given. So conversations which the patient might have had, it can be to any doctor, but especially people like psychiatrists, psychologists, or counselors. You may understand the patient's problems, in-depth analysis of a patient's problem, and still we need to keep our conduct as relevant as possible. Only disclosed information which would be relevant to the patient, which would only be relevant to the setting. That, for example, if it is in a court of law and you are asked to reveal a certain problem or a certain condition of a patient, that is the only place, and that also to the limit that is required to. Not all information, or not the entire information, needs to be revealed. Again, failure to notify any venereal disease or infectious disease again comes as a professional misconduct. Treating patients under the influence of drinks or drug, again, for the doctor itself. So this is a very common practice seen in any kind of a setting. And there are individuals who have questioned us, saying that what is the limit of alcohol that may be limited or permitted. There is no limit of alcohol that has been permitted till date. The point is that if you have consumed alcohol or drugs due to any reason, okay, then you should it is mandatory on your part to understand yourself that it is not right on your part to go ahead and treat the patient, because you may be not mentally stable to take the decisions that might be required. There are individuals who may claim that this much amount of alcohol or drugs don't affect them, but as per rules and as per guidelines, we are not supposed to treat patients under the influence of drink or drug. P-splitting of dichotomy, to understand, is there are labs, there are institutions who send you cuts which they claim as this is something which is for you, which is meant for the doctor. In that, like for example, you do a CT scan, you do a lab test, and there is a certain amount of money which needs to come through that. And if and even if you take it or you don't take it, it is supposed to come to you. That is called fee splitting or dichotomy. So that is one of the easiest way to understand about fee splitting or dichotomy. And those are things which are also not allowed at any given cost or manner, and also considered under personal misconduct. Coming on to the second thing in medical law and ethics that you need to understand is professional negligence. So negligence at any cost is going to be difficult to handle in the court of law. So negligence is doing something which you're not supposed to do, or failing to do something that you're supposed to do. So in medical professional negligence, the absence of reasonable care or skill, or willful negligence of a medical practitioner in the treatment which he causes bodily injury or even death of a patient can put you into a criminal malpractice level. And civil negligence would be, for example, the case studies that we discussed earlier. That is, you are on duty, like for example, the TB patient who was not taken care of. That is all civil negligence. So it is your duty to take care of the patient as and when the patient comes. If you think you cannot take care, it is your duty to refer this patient to. So failure of the part of the doctor to maintain any applicable care or skill. So it's not necessary that every doctor is going to know what is needed to be done. So if you don't know, it's fine. You need to refer the patient at the right time to the right place, at least. So that's a part of the duty. Any direct causation, that any damage that was caused in the breach of duty. So you see that the patient is sick, and yet you decide that, oh, it's not my duty, it's not my time. So, and you walk off. That is also a part of direct or damage that can happen. And it's also a part of the criminal negligence. Any damages or lost wages, medical expenses, any mental unrest that is caused just because we decided not to take care of the patient is also considered as a part of civil negligence. Now, when I say criminal negligence comes to any case or any situation in which the patient might either experience a near-death situation, or patient has died because of a certain misconduct or certain reason that the required doctor did not act into. So when we say that, it is not everybody who dies goes to a court of law, but there are individuals who go to a court of law just and approach themselves just to prove the fact. So a case will never be taken, a medical case will not be taken as a criminal negligence till we prove the fact that actually there was misconduct, or there was a lack in the timing or the proportionate care given to this patient, and that this doctor knew that this is the care to be given, but wrong treatment or a wrong timing was done. Just for simple examples, leaving instruments in the body during their surgery, one of the most common criminal cases. Prescribing a wrong medication, or writing the right medication, but the nurse having prescribed the wrong medication, or giving the wrong route of the medication, leading on to chemical anaphylaxis, etc., and leading to a death of the patient. So in such cases, we use something called as res ipsa loquitur, which means that the thing or the fact speaks for itself. And one of the basic things is that without seeing that, without really understanding the fact that, oh, the instrument speaks for itself. If the instrument was found inside the person's body, there is nothing more that needs to be proven. That is, it's just straight away taken as a criminal negligence. Yeah, so we did discuss a lot about consent in the topic of autonomy. Just for a little bit more revision, which would be consent is one of the most important part of medical profession, starting from taking the history to even touching a patient. Consent needs to be taken. It's an agreement, it's a compliance or a permission which is given voluntary and without compulsion. So it can be verbal, it can be written. That is how it is expressed. Implied is like always or consent always has to be in writing if you're dealing with a medical legal examination. But you can express a consent with, like, for example, you don't really like the examination, but you know that that examination is necessary for you. So you express a consent by maybe nodding your head or using your hand. The patient consents it. And even before a normal medical examination, you need to take a consent. You need to approach yourself saying that I am going to do so and so procedure. It may look weird, but and it may look very dramatic as it is shown in various medical serials, etc. But it is a part of our job to do it. It is a part of our responsibility to take a consent. Then there's something called an open consent, where especially this comes in case of genomics, etc., where you know that once you've given your data can be openly used for the use of genomics, etc. So it's not something which is common, but it is something I put it here so that you know that such a things exist. So in India, children below 12 years are not valid to give consent. So you would have a surrogate, which would be their parent or their guardians who would be giving the consent. So ideally, it is the parents who give the consent in the case of children. This is not just valid just for a surgical intervention, but for any intervention that, or any examination, or even maybe just giving vaccination, you need to take that consent, and then that is how it is supposed to be done for children below 12 years. It varies from state to state, but in India, that's why I put it 12 years. Children below 12 years are not valid to give consent. There is a surrogate who gives a consent. Loco parentis is something where a child does not have his or own parents, but has a guardian to give the consent. So there has to be a valid reason why the parents are not giving the consent, and there is a guardian who's giving the consent, and that is how you would be taking the consent for the treatment of this individual. So to assess the patient's capacity, it always varies according to the patient, and it's a very complex decision. And again, like we discussed in the various case studies that we discussed before, the patient may imply of not giving the consent, but you have to see how vulnerable he is, what understanding, what state or situation he is in, and then we may come to the conclusion that who would be giving consent, whether it is himself or it is a surrogate who will be giving the consent. Coming on to informed consent, again, this was something which was already discussed. It is basically you discuss in detail the ailment or the disease process. You discuss the nature and plan of the treatment. You put an alternate line of treatment along with the risks and the relative chance of benefit and success, and even the failure, and give the person the freedom of choice to decide whether the patient wants to go ahead with the thing. Apprehension, fear, containment, everything would be a part of it, but it is our duty to, like I shared before, to make our confidence in our patients, to say that, okay, we are doing for the best of you. We're doing this because we want the best for you, and these are the treatment options that you have. So that is your choice how you would make that. But if given a choice, this is one of the, so maybe stepwise making them understand that this is the best way of taking that. There is always a question which is asked during informed consent, which is that, do we scare patients too much by giving them information? It can be a yes or no. It can also be as much as to how the understanding of the patient or the individual is or the person or the individual is. But also, like I said, it is a responsibility on our part to make the person understand in their understanding level or in their language as to what. Because see, like for example, a medical treatment may sound simpler as compared to a surgical treatment. So a surgeon always will be looked with the eye of suspicion, like, do you really need to go in for that surgical treatment? So so giving them death on table can be one of the last things that you would want a surgical person to have it, but still you need to make the person understand all the complications that may be that the person, even if it is in the case of a child, that what exactly the complications can be due to, in this condition or in this surgical procedure. So it's not to scare away the patients, but definitely it's also to for them to understand that there are risks involved in every procedure that we do, even if it might look as one of the most simplest of the procedures. And if you don't give a consent, if you're giving consent again under fear, misinterpretation, or if the consent is given by an insane or an intoxicated patient, it is not valid and it comes under section 90 of an IPC. And we should know that we are not allowed to do it. It is also an offense when harm is caused by an act, like, for example, you did it in good faith, even without consent. So that's the double effect. Under circumstances when it was not possible to take a consent, you did that, and the effect turned out to be, obviously if it is good, nobody would question you. But then if the effect was bad, you may be questioned. But under section 92 of IPC, you will be covered. You will be covered under the harm, and it will be taken as it is done under act of good faith. And consent is necessary. It's very, very necessary, because it saves us from assault and battery, and it also protects us from negligence, because you have explained to the patient what you're going to do. This is the end of my session, and I leave you with just one thing. This is for each of us who is working as a medical practitioner. Over a period of time, these 5 C's are something that I think which were taught to us in the beginning of our medical career, and that is when we take a history of an individual, when we are taught that to diagnose, when we are taught to examine a person, when we document. Over a period of time, as our position increases or as our experience increases, we realize that the diagnosis shorten, the words shorten, sometimes there is just one piece of word written on an entire paper, and then some few medicines prescribed. But the correct way of documentation for any disease or any condition is that it has to be concise, but it has to be complete. It should be clear and legible. Okay, correct is definitely a misnomer, but then correct to the best of what you have diagnosed the person. It can be a wrong diagnosis. That is not what you felt, that this is how the patient presented to you, and this is how you want to go forward with the treatment. So the correct terminology used in whatever you were trying to imply, and it should be in chronological order. So something to take forward from here, something which we are not putting in practice. Even individuals who, like us, who maybe be over the practice of 15, 20 years, this is something that we are shortening it. But to prevent ourselves from medical negligence, to prevent ourselves from all law related activities, this is something that I think we should take forward with. So thank you, and I would leave you to ask questions either on the chat box or directly, but also leaving it's a part of one part of the session that we are trying to finish now before we go into the plenary. And what I would encourage, like I shared in the beginning of my session, was this conference is just a teaser. It's just something to inculcate that that spark in each one of you to understand that bioethics is something which is really important, and really something that we all should understand in depth if we are doing medical practice. And today should be just a beginning to understand that during our medical practice, the amount of complex cases that we deal on a day-to-day basis, how are we supposed to do it? Do we have help? Do I have the critical understanding to take care of each of these conditions, not medically but ethically? Am I right in taking those decisions? So just to give you a little bit more further is I would encourage each of you, if that spark has been enticed in you, I would I would encourage you that you should go forward and try to learn bioethics further. There is a PG diploma course run by the Christian Medical College Vellore in association with the Center for Bioethics. It's a 2-year PG diploma course, and I would encourage each one of you to try and do that, because it would definitely take your skill and your understanding of bioethics to a different level. Also, there are 2 books which have been published by the Center of Bioethics. It is specifically on the practical bioethics in the Indian perspective, because most of our literature that you would go, even if you want to address literature, you would find literature from the Western point of view. So these 2 books, you would find many people who you have met today, or if you've seen speaking today, they have been a part of the contribution. But it is a more practical oriented approach. It is also takes into consideration the various extra parts or extra things which needs to be considered in bioethics, especially finance, which is a huge major component in dealing with medical cases in India, and or medical decision making. So yeah, so that brings me to the are there any questions that that you would want me to address? There's a question by Melba, I think.
Yes, ma'am.
Yeah, Melba, I'm just trying to read it actually. The legal framework in your country seems to be very advanced in terms of considering the interest of both providers and users of service. Are there any circumstances where the legal requirement contradicts ethical obligations? Have the courts in India had to deal with any case addressing? Could you be a little bit more specific, Melba? Yeah, Melba, if you could unmute and be a little bit more specific.
You can unmute, Dr. Melba.
Okay, thank you. Hi, how are you? My name is Melba. I'm a bioethicist from Kenya. Thank you for the rich discussion. I think this is relevant for us because our legal framework borrows heavily from the Indian one. I was just wondering, in terms of your legal system seems to be far advanced in terms of providing a framework, for example, for withdrawing and withholding, and like you've really contemplated the challenges that medical practitioners face as they're making difficult medical decisions. I was just wondering whether there are any circumstances in which the legal requirements, so something that, so for example, in Kenya, abortion is restricted. And so where you would be in a position to apply your ethical obligations to actually provide a service for the benefit of the patient or to prevent harm, then the legal framework prevents you from doing that and probably has a criminal sanction attached to that decision. I was wondering whether there are any circumstances in India where the legal framework prohibits us from effectively applying ethical obligations.
Yes, we do have, Melba. Okay, I was just taking some time to understand your question. Yes, we do have, especially in the case of abortion. So legally in India, by law or by the MTP Act, we are allowed to we are actually allowed to abort till 20 weeks of gestation, which has now been shifted to 24 weeks of gestation in certain specific cases. It's not for everybody, but certain specific cases where there is, like, especially there's congenital anomalies involved. That is where we take it till 24 weeks. But in the court of law, there are in the term of abortions, there are abortions happening at 30, 32, even at 34 weeks of gestation, which is a fully valid and fully it's a mature, it's a baby who can survive separately, or it doesn't need the support, because 34 weekers are kids who can survive naturally. So those are contradictory cases which
which are different from the law of the country, which is till 24 weeks, but in conditions. So recently, just about a week back, there was a law passed by the Supreme Court. Like the High Court had cancelled a judgment by the Mumbai High Court had cancelled a judgment where a victim, a 14-year-old girl who was a rape victim, who was cancelled by the High Court, saying that the verdict was you cannot carry the abortion because the child has already crossed 30 weeks plus 6 days. But the Supreme Court overruled that judgment and allowed that the abortion be conducted because it's a special situation and it's a sexual assault, and that is why you can go forward with in termination of this pregnancy. So yes, there are cases in which contradiction can happen. And so is with DNR support also. So active euthanasia is not something which is practiced in India, or it is not legal in India. But even but in spite of that, there are certain conditions where people have approached the court for discontinuing supportive system.
नहीं तो आपको कहीं से कोई डिजाइनर वाला अवार्ड तो मिलना नहीं है भैया.
For discontinuing life supporting system, which was against which is against our rule of law. And so yeah, there are situations in which people have approached the bench asking for some different decision per se. I hope that clears, or it is similar, or you're expecting. I'm not sure. I answered how I understood, I guess.
Yes, thank you.
Are there any more questions? Or maybe we can leave it in the chat. Elliot, how would you want?
Yes, ma'am. They can ask you.
Dr. Rupa, can I ask you a question?
Sure.
Can you explain the relationship between law and ethics, and which is supreme? And if there is an entangling situation between the law and ethics, what do you have to say for the medical professionals? How do you handle a situation which is conflicting between law and ethics?
I personally would say, see, it's not a straightforward answer, because law and ethics cannot be placed on different platforms and say that law is correct and ethics is correct, because law has been placed as the law of the country. And wherever you're functioning, wherever you are, whether you are in India, whether you are anywhere abroad, you would need to practice the law of the place. But ethics is something that we need to understand on a personal basis as to what we want to do. It's something that is imbibed in us, which is something which is, as medical practitioners, we need to put ourselves into understanding each situation, each medical ethics situation in a different platform, in a different way. Answers cannot be given straightforward. That is why ethicists have put their questions, or when you're faced with a situation in ethics, you put yourself into the 4-box platform, like the Johnson's 4-box criteria, where you put the situation, you look into the situation, you look in what is beneficial for the patient, what condition that you have, or what is the platform that is available for this individual, which would benefit this individual. And once you come into a conclusion that, okay, this would be the best answer for this person, then you go and approach or look into the law of the land, whether it is possible or not. It is going to be intertwined. I would not say that one is above the other, but there are conditions, like, for example, abortions. There is also our faith, which through which there are certain decisions which are which we pull back, or which we don't which we are not happy to take, or which we feel is wrong. And that is not something that can be enforced on a larger platform, on a secular ethics platform, but it is something which is personal. And if we are talking about faith-based ethics, then the faith-based ethics the balance for the faith-based ethics would be on a higher platform. And I think that is exactly what we are going to be covering in the next session, which is a plenary, which is how are you going to take the 4 pillars of ethics or the 4 understanding of ethics, ethics, and put it into a different lens of understanding that, oh, if I am faced with such a situation and the law of the land says something else, how am I going to deal with it? What is going to be right and what is going to be wrong? So it's going to be a complex answer. It's not going to be a simple answer of yes and no.
Yeah, thank you very much.
Any other questions? I guess, Elizabeth, maybe then we can.
Okay. We wait or
How do you want to?
or else shall we ask them to post in the chat box and take it later? So feel free to post in the chat box so that ma'am will be there to take up the questions after the plenary session.
Sure.
Next, thank you so much, ma'am, for sharing. The next session will be by Dr. Santosh Matthew, sir, and he is a professor of medicine nephrology at CMC Ludhiana and has held various leadership roles in the hospitals across North India since '92. Sir is trained as an internal medicine specialist and worked in Duncan Hospital, Raxol in Bihar. He is currently the training coordinator and regional secretary for South Asia at the International Christian Medical Dental Association. He's married to Saira ma'am, who currently heads the EHA. They are blessed with 2 children. Over to you, sir.
Can you see my slide?
Yes, sir.
Okay.
But not in full screen, sir.
Not in full screen? Okay, sorry. It's not in full screen?
Now it's just sharing, sir. 1 minute. Yeah, now
Yes.
it is.
Okay. Okay, let me correct. I'm not a professor. I'm not a professor of nephrology or anything. I'm just a physician. Okay. I would like to appreciate all those who have been here from 3:30 to 7:38. I would have walked out halfway through. So much of very intense inputs. So I think all of you should give a clap to yourself. Of course, to the 5 people who presented, definitely yes. But more than that, I think you should give a clap to yourself. Sitting through, I don't know how many hours of how much of inputs is there. So maybe you can all put a clap for yourself because it is not easy to sit and go through this intense and following after 4 bioethicists this session. Not easy. But what I'm going to do is to try to pull together many things we have heard and look at this thing and talk about some 4 aspects of thing to pull together. And I'll also put some case studies. I hope that we'll have some discussions alongside. So I'm going to look at the 4 biblical bioethics principles, the 4 bioethic principles which was talked about today, and what are some limitations. And then look at the changing context of the world and the value systems. Things are changing so fast around us. And what is emerging understanding in the bioethic field today, and how do you live and engage in a changing world of today based on our foundations of Bible. We talked about the autonomy, okay, respect for every person to desire autonomy. We talked about no harm. I think Priya talked about it. Satish talked about beneficence, and Jamila talked about justice. Each of those are very important. These are our foundations, well accepted global foundations. But remember, these were based on a common morality which when Bucamp and Childress wrote it, they based it on a common morality of a well-accepted common minimum platform of say these are the moral standards of the world. But today it is not relevant anymore because there are no common moral standards. Let me put across a case for you, a patient, not a case, a patient who, a friend of ours actually. I'm going to read this case and a patient story, and you can put it in the chat. What would your advice be? It was at the middle of the Delta wave. Large numbers, this is in Delhi, large numbers of patients are waiting for ICU. Here was a 36-year-old young man, with a diabetic, morbidly obese, who was in the ICU, kept on an IV. At the same time, both parents were admitted in the hospital, the private room, very stable. Late in the evening, around 8 o'clock, they come for round, doctors come for round. They tell the parents, your son will need ventilation any time at night. We don't know whether there'll be ventilators, but at that time, we don't want to run around and ask for consent. Please give a consent now so that we can take the decision. But one thing also to remember was that the boy was a boy with a Down syndrome for the last 38 years, and he's autistic too, but very well loved by the family and the extended family. What would you advise? Would you give consent for ventilation? I just want a quick answer, yes, no, and think through why would you say that answer. Any thoughts? Can you hear me? Elliot, can everybody hear me or?
You are audible, sir.
Yeah.
Yes, we can hear you.
Yes, sir.
Yes.
Yes,
Yeah,
sir.
just put in the chat whether if you are the parent, would you give consent to ventilate that boy or no? If not, why? Just think through. Just say yes or no. No, not not blank. Okay, yes. The whole question was, how do you decide? Autonomy. Whose autonomy was here? That boy had no ability to give answers. That boy has a sister and a brother, and they're married. There's an extended family. Is their autonomy more important, decision more important than the parents or the doctors? Look at beneficence. We knew that at that time, there was only 30% of ventilated patients with comorbidities would survive. So would it be beneficial or would it be harmful? Or would ventilating be harmful? And there are many others who are much more eligible with no comorbidities waiting. In that context, is it justice? Is it just to give this? Now, why I shared this story is this patient was one of a very well-known patient to me because I used to take care of him before COVID. So I know the family very well. At 10 o'clock, a call is coming and saying, can you help us think through this decision? What would I say? Now, remember, bioethic principles are not prescriptive. Behind every decision, remember that there is a human being. We should never reduce medical ethics to a few theological principles or moral principles. Now, don't forget the human being that lies behind every ethical dilemma. I have used a lot from John White's Matters of Life and Death in this presentation, and I'll talk about it later. So our first duty is to recognize that when an ethical issue comes to us, there is a human pain, despair, and perplexity. Our call is to wrestle with those dilemmas, not with very dogmatic saying, this is the answer, I know the answer, or you should have done this, or judgment, but broken hearts. Because that is what we find in Jesus. This hospital is not a commercial hospital. So that is the first thing to remember. Principles are not prescriptive. Principles are only helpful to journey with the patient with compassion and broken hearts. But at the same time, second thing to remember is look beyond the principles. Because principle works when there is a value system behind it. As I said, when Bucamp and Childress wrote those principles, they were based on a Judeo-Christian value system, at least a common morality. So it depends on the worldviews or those values which undergird those principles through which you will interpret those principles. So the question is not whether the principles are right, but why are we deciding what we are deciding, or why are we suggesting what we are suggesting? In the context of the world, there are multiple value systems, or in one sense, worldviews. Each worldview will look at those four principles through different spectacles. For example, this is a very heavy slide, busy slide. I don't worry about it, but I just want to highlight two things. Today's majority world is scientific naturalism or materialism. That is in the context where all of us are taught, saying that body is just material. It is material. Everything is material. Man is matter. Truth is scientific. There is nothing called morality. You have to explain by science what the truth is. So there is no objective values. So even bioethics, you break it down into say that, okay, science says this, so let's do this. On the other end of the spectrum, if you look at the last thing, we live in a context when everything is relative. Culture decides what is right. Everything is culturally constructed. Truth is related to what I think is right, or the culture tells me. Everything should be tolerated. Everybody should have the freedom to decide what they want. Everybody should be included. And, refusal to claim to have answers is the answer. I don't know. That's okay. You do what you want to do. In the middle of that, we have the Judeo-Christian world system, which says there's a personal God who created us in his image. There are absolute values. So it's in this context we need to understand that principles alone doesn't make sense unless the value system behind it is clear. Now, what are the two clear contexts in our world today? One is, on one end, it is the scientific materialism as the dominant worldview. It was Rene Descartes who said, I think, therefore I am. That led to an understanding that if I can logically explain through science and scientific principles, that is what is right. All the rest is wrong. All this morality discussion is of yesteryears. Okay, there was a religious era. Today it's a scientific era. That's on one side. On the other hand, there is this expressive individualism which says that I feel this is what I am. That is true for me. Look at the whole gender issues and identity issues. I am born with an XY chromosome, but I feel I am a woman. So scientifically what I am is not physically what I am or emotionally what I am. I feel this is what I am. That is true for me. So you have this two extremes in the world today. On one hand, say that science is not the answer. What I feel is true. I feel, therefore I am. On the other hand, we scientists would say, come to science. And John White in his book explains this very well through 5 transitions. He says, one is the human biology and the triumph. We say that we have triumphality, especially the AI and human augmentation. We're just machines, but we can now augment ourselves. We can transcend ourselves. The whole today's thing is to how we can machines and human come together and augment ourselves. On the other hand, there is also the saying that it's all by chance. So what's the point? So humanity is struggling with, on one hand, saying that we are triumphalistic, we can transcend. On the other hand, we don't know what we are. At the same time, biotechnology has come so well. Yesterday, we would say an embryo was begotten by God. Today, we would say an embryo is made by human in the laboratory. So we can control the quality of our genes, our beginning and end of life. We can decide when you want to die or how we want to die. That is the context. And this has led to a consumer expectation. I want the best genetic progeny. I want the easiest way to die. If I am not useful, let me die. And countries would look at policy and say, if taking care of disabled children is economically not viable, about them. Economics should decide. Forget the divides. That is, all will catch up. And based on this, there is an adventurous playground around where people are redefining bioethical foundations today. These 4 principles we talked about are being pushed and said that is of the past. Look at these statements from Richard Dawkins. They're just survival machines, programmed to preserve the molecules as genes. And another writer goes on to say, an embryo in the tank is a product of human planning, ingenuity, and forethought, an artifact of human creation, no more created by God. So in a context where there are no common values or denominators or common morality, the question is, will these 4 stand the test of time? How do we understand this? So much so, we know that in Europe, France, UK, and countries where prenatal testing for Downs is mandated, and based on NIPD, prenatal testing, non-invasive prenatal testing, based on that, in 2018, the number of abortions for Down syndrome had increased by 50%. 2022 study says almost 70%, which means in a decade's time, there will not be any Down syndrome children being born in Europe. Why? Because caring for a Down syndrome baby or child is more costly for the NHS than doing abortions. A decision is based on what is economically best for the country. Let me put another case, patient story here. I saw the answers earlier. He said, outright no, will not. Look at this lady, 30-year-old priming, precious pregnancy. Look at the process with which she went through. Big Christian, she prayed for a baby, waited, and finally became pregnant. Routine non-invasive testing is part of the routine thing, so it turned out to be positive. Immediate anomaly scan was done. It showed some mild changes, was unsure. So said immediately get a full genetic testing. The test came out trisomy 13 positive, that is Potover syndrome, which is incompatible with life. The next immediate step was go and get a chorionic villi sampling or amniotic fluid. They were reflected on it and refused. Then they were said, okay, wait for another 6 weeks and get the ultrasound, then we'll take a decision. 6 weeks later, we found an ultrasound showed there were multiple anomalies, and it was said that it might be threatening for the baby if it was born. Go get immediate termination. What would you advise? What would your answer be? What principles would you use? This is the now standard of practice in most urban centers. Clear steps forward. Do this, if not do this, if not do this, if not do this, or terminate. What would you advise? Just a few thoughts. Should I advise them? What would you advise? Go ahead and put your thoughts in the chat. I know these are complex situations, but end of the day, very important, should we know anomaly scan at all in that kind of thought? An important question. Is that the standard of practice we should follow? Very important question to ask this. These standards of practice, would it lead to a increasing number of abortions? I don't know. Any other thoughts on this? Very complex. To go with children's parents is very important. If it is incompatible, why terminate? Wouldn't it take care of itself? Very important question. But that is not the standard guidelines. It says that incompatible with life, terminate before 24 weeks, 20 weeks. The guidelines of practice. So the whole question is, how do you take care of this? So in this changing, life is life, very important. We need to deeply empathetic because it's not easy, very important. That is what we need to understand. It is not easy. So in this changing context of value system, there is a whole lot of other ethicists who are saying all these old four principles based on the value systems are no more relevant. There is only one overriding principle, autonomy. I can decide what I want to do with my life. No life is good if lived against the grain of conviction. There's a whole group of ethicists who are now saying that we are living in a liberal, individualistic world where we can decide what we want for our future and our life. Peter Singer and others would go a few steps ahead and say that not all humans are same. A newborn or a fetus is not as worth as an adult who is able to work. And as a society, we should take the responsibility. If it is immoral to allow a human individual to linger on in a condition that's not worth living. I wonder if this was the principle. My mother died of Alzheimer's. We took her of for 1.5 years. Last 6 months, she had no memory. She couldn't understand any of us. Was she not worth living? Was I immoral in allowing her to linger because she had lost humanity? But that is the context in which medicine is. And respect a person to decide to live or die. He can decide, he or she can decide. And also go to the level to say that human babies are not born self-aware. They're not persons. Their lives are no worth your protection than the life of fetus. A newborn child and a fetus is saying they're not equal to adults. They have all the way gone ahead and say that humans are no different from other animals. Do not discriminate even on species. Interestingly, there are laws being passed in Australia based on this, saying that animals are equal to humans. Very interestingly, Peter Singer writes about this, that all human members of the Homo sapiens are not all persons. Not all persons are members of Homo sapiens. They are one of the many. Why I'm sharing this is important to understand that we are fast progressing into a system, into a value system, which takes care, which undermines all what we have believed in the past. Let me put another situation for you. There's a 90-year-old man, very well, without moderate renal failure, but absolutely fine, very senior pastor, very doing well. He just fell and broke a pubic bone. Being a senior pastor, the church leaders, the bishops all called and said, hey, he has to be taken care of, shift to ICU. But the son was told by the father, do not take me ever to ventilate or ICU. Let me go when it comes. But there was the extended family, the bishops, all. You get a call. What should I do? What framework would you use? And being a biblically founded family, they were asking this question. From the Bible, how do you advise us? What do you think? Any thoughts? How will you advise this family based on some biblical frameworks? If you look at autonomy, he wanted to die. If you look at beneficence, it is only a pubic bone fracture. If you take care of the pain, he might have lived for another 5 to 10 years. He could have been taken to ICU and given put in morphine, drip, and taken care of. But would he get another infection? Would be doing harm by taking to ICU? What about justice? Would he put as an 89-year-old person into ICU when others are waiting? Yes, thank you, Arnab. What was the right thing to do? Very important to understand that in this kind of complex situations, it's easy to talk to the Christians, but I will come back to other aspects. Does the Bible teach us? Does it have anything relevant to the context and complexities which are in a totally different society? I believe it is there. I think we need to recognize that though the bioethic principles are important, those principles have to be seen through the foundations of biblical values. It is John Stott who divided human history into 4 epochs. He said there was the creation, there was the fall, redemption, and future hope. And John White, in his book on matters of life and death, explains this further to say that these four should be our foundational values through which you look at biblical about the principles. I think it's very important for us to build on this. What does that mean to us? The first thing, let's look at this four quickly. One, we are created by God. We are created in the image of God. What does that mean? It means that our value comes not because of our intellect, not because of our abilities, but because of something greater than us. We are the derive meaning outside ourselves. Because the image is put into us, we find meaning. We are reflections of another reality. We are images, reflections. So our dignity comes from outside, not from our ability, not from our utilitarian looking at that, whether this child has the ability or this elderly man is utilitarian, is useful to the community or not, because they have the image of Christ. Whether it is the Down syndrome boy or the 90-year-old father or the unborn Pato syndrome baby in the uterus, in the fetus, as a fetus, all have the image of God. Which also means that because God loves, I find meaning. My being comes from the fact that I'm known and loved. Not only me, every patient we come across. And each person who we come across are his children. Whether they are unborn or a vegetative, a person on a ventilator who's maybe brain dead. Which also brings us to the fact that every human has dignity because God's image is in, and all are equal. I think this foundational understanding has to be very clear for us as Christian healthcare workers. What would that lead to? It would lead to looking at humanity with wonder. How did God create this complex fetus with all its marred problems? How did God create this complex elderly whose systems are still functioning, whose mind probably through Alzheimer's is going on, but can still communicate from the spirit to God? That's what I experienced doing my own journey with my mom. She could not understand who I am, nor my father. But deep in her heart, when we sing a song, she will be smiling. Because she will understand that something beyond her intellect, she was experiencing God's presence. A wonder, I respect that these are created, humans are created not as machines, but it's much more. At the same time, when you look at people who are in pain and suffering, who do not have the abilities, we look at them and see how we can protect. We look at the mother who's struggling with the whole issues with empathy. But at the same time, we should remember that we will one day return to the dust. Though we came from the dust and will return to the dust, we are frail. We are also special beings. Very interestingly, now C.S. Lewis in his book Consecrated Pilgrim says, we are a disgusting hybrid. We are not animals. We are not pure spiritual life, but we are a unique creation, a hybrid of humanity and spirit. And then C.S. Lewis goes on to say, none of you whom we think, whom we see across, none of them are mortals. These are mortal, but they are immortals. But we are part of one family. So very important to hold this into our understanding of what humanity is. At the same time, remember, we are fallen creatures. Death and decay is part of our life. There are a lot of movies coming out on immortality. The last one, the earliest was something called Tuck Everlasting. If you're interested, you can go. Each of these movies finally come to a point and say that immortality is not worth aspiring for. Growing old is worth aspiring for because they're realizing that a severe mercy, like C.S. Lewis said, death and decay is a mercy, because immortality will destroy us. Of course, we are frail and futile. And that is why God in his sovereignty stopped us from having immortality when we fell, because our fallen creatures cannot live immortal. But he brought in redemption later. And suffering is part of our life. There is no answer for that. The only answer is that a God who suffered with us, journeys with us. And every technology which we create would end up being corrupted. But our hope is that the redemption is already done. There was a day on the cross the redemption started. And there will be a day this will be consummated. What does that mean to us? When we come across patients who are struggling with this, how can we bring the redemption story there? We find in the Old Testament the portrait of the vulnerable. God in his sovereignty said that every community, the Israel nation, should take care of the widow, the orphan, the poor, and the immigrant. Jesus, as he started his ministry, talked about the five communities he will take care of: the blind, the oppressed, those in prison, those, as if to say that the vulnerable, the disadvantaged are core in the redemption story. It's not that it's only for them. And we find that time and time again. But so as healthcare professionals, our role is to defend the defenseless. Who are the defenseless around us? We don't have to look around much. The fetus is defenseless. The newborn is a defenseless. A brain damaged adult is a defenseless person. An elderly person with Alzheimer's is a psychiatric mental health person is different. You don't have to look around. They are defenseless. Our role as members of the redeeming community is to be defenders for them. And not through our abilities, because Jesus role modeled through a dependent life. He was not independent. He was dependent as a small child born in a manger and died with no ability to save himself. He gave up that and cried out for us. It is in that brokenness that he brought redemption to us. It's very important to understand this, that this is the model we have. So suffering, with people who suffer with questions about ethical issues, do not need an answer immediately. They need people like you and me to journey with them, to make them understand that even through this difficult choices they make, you can find strength because there's a God who journeys with them. And finally, all this makes meaning because we know death is not the end. There is a future hope. What people are going through makes sense only in the light of the future. We can dare to act only in the light of the future, because tomorrow, even if that Patau syndrome child dies in utero, you will see him or her in eternity as a child rejoicing in God's sight. That's the hope for us. Now, it's theoretically very easy to say. My question for us as we conclude in the next couple of minutes is to ask this question. Each of these stories which we talked about, how can we see them through creation, fall, redemption, future hope principles? How can these values talk into our autonomy, beneficence, non-maleficence, and justice principles? Let's look at this case. This was a patient. This was actually in Duncan Hospital, Raxall in 2020. This lady was brought at 28 weeks of gestation. This was the first visit to our hospital, already ultrasound done, life-threatening deformities of the fetus. Non-Christian, there's a Hindu family. The baby was alive, and the family was very clear. This baby should be destroyed, terminated. And as I was asked, can you just talk and tell us what to discuss what to do? So I went, I'm not a obstetrician, but then being gray haired, they said some gray hair wisdom might be helpful. So I went and talked to the patient. Mother was crying. She didn't know, I don't know what to do. She said, it is my fate, it is my karma. And she knew that the extended family was telling that you are the problem. You brought it. If it was another lady, it wouldn't have happened. They were putting all the blame on her. But I sensed that there was a mother's heart who did not want to abort that baby. But there was a wife's heart who wanted to be obedient to the mother-in-law and the father-in-law and the husband. What would you advise? How do you see it through the biblical framework? Whose autonomy is here? Is this baby created in the image of God? Is this woman created in the image of God? Is the mother-in-law and the father-in-law and the husband who don't even understand this created in the image of God? How do you communicate that? How do you bring the redemption story to this lady who is thinking that she's at fault? To communicate that you are not at fault. It's part of the broken world we live in. How do you bring hope in the situation? I know parental palliative care. Yes, it might be answers might come from different ways. But the important thing to understand is that our role is to use these values. The creation, every human is created in the image of God, including the mother and the child. Yes, in the fallen world, there will be situations. We are called to be people who bring this redemption story or the presence of a God who journeys with them into their lives and give them the hope that there is something beyond this. At the same time, logically think through and help them to take the right decision which is for them. Let me come back to this 3 or 4 stories and conclude. What happened to this boy? Very interesting. I still remember this. At 10 at night, they called and I told her father and mother, look here, I can only say logical things, medical things. I can tell you that there's only 30% chance of a ventilated man who's diabetic, obese, with comorbidities to survive. It's your baby, your child, you've got an extended family. You know, he's created in your God's image. He's equal to you. He's your loving son. You need to take a decision. I can't give an advice, but I had to put what is it? If I was in your position, I'll pray and think much more. But you call your family. And interestingly, they had a family call midnight, but told the doctors, give us 12 hours. Tomorrow morning, if something happens at night, do not ventilate. Tomorrow morning, we'll give an answer. Whole night they spent with the extended family on Zoom call, and finally they took a decision not to ventilate. Cutting the story short, this boy pulled out his NIV, walked out of the ICU, and came to the private room and said, I want to sleep here. He recovered that night. I mean, that was God's miracle. And even today, these two husband and wife keep telling me, you told he will die. God had other plans. I mean, it doesn't, that is an unusual story, but it doesn't happen always. But I'm saying there is a God beyond what we can even think or imagine, who will work, journey with families when we journey with them. What happened to this? It was an extremely difficult 4 months. It's a close family friend. The pain with the family went through was much more than the decision. The decision was simple. What happened is finally the baby died in utero. They terminated, they delivered the child. We had a memorial there, we had a burial and a nice time. But because of this decision makings in the obstetric practice, these 4 months of pain they went through, one after another, was the person has not got out of it even for 1.5 years now. How do you look at medical practice? Let me tell you, this was my father. This answer, I had to give the answer. I couldn't take a decision. I handed it over to friends of mine. And my friends were doctors who said, look here, his heart is that you will not ventilate him. Please do not. If anybody pressurizes you, we will stand there that we are the doctors. We will take the blame. I had colleagues who journeyed with me to say that we will take the responsibility. You stand strong. An interesting story. Let me end with this. At the end of, after the funeral, after my dad died, his closest friend came to me and said, Santosh, your father had only one desire. I said, what? To die in your hands. I said, he never told me that. I said, that's true because you are out in Bihar. He never expected you to be around when he dies. But then God in his sound saw to it that you are there when he died. Now, it broke my heart, but I realized there is a God who does more than what we can imagine and think when we follow the little we know based on godly principles. Priya showed this. I want to end with this very clearly. What we need is this foundational Christian values. Creation, fall, redemption, and hope. Just those to speak into our biblical values, into our bioethic value systems, principles. And how do you get that? It is only by constant communion, fellowship, and discussing how each situation can be addressed through a biblical perspective, at the same time using bioethic foundations and helping the family to journey in the midst of this pain. We are called not to always give answers. Henry Newman says, it is very difficult. We are called to be compassionate because our inner disposition is to say that you should do this. But our spontaneous response is, not to go into the pain of this, but our call is to walk with them, journey with them, and help them to journey with a God who is journeying with them and take the best right decision which is possible in that context. So let me end saying that if you want to do more and learn more about this, please buy this book. Excellent book. And ICMD has a training on bioethics on a regular basis. You can join. So let me conclude with that one thought. This is the 4 foundations we need to hold on. Every human is created in the image of God. The autonomy comes from the image of God, whether it is unborn child or a dying elder. But suffering and pain is part of our life. In the middle of that suffering and pain, there's a God who journeys with us. And we are called to be his hands and feet to journey with others. There will be a redemption. Even pain can be redemption. But all this makes sense only because we know that tomorrow there will be no pain and suffering. So build your foundation strong on principles of bioethics. But more than that, build your foundation's values strong on the biblical principle, which should undergird all the principles of bioethics we will engage with. Thank you.
Thank you, sir, for explaining it more practically with practical examples. Anybody else would like to ask questions? Kindly please ask. I suppose Rupa ma'am has question. You can unmute and as well ask questions.
Yeah, Eric is asking, we can't impose our ethics on others. Yes. Our journey, our call is to journey with them with compassion and sensitivity. But in that journey, God might give us opportunities to bring issues related to beginning of life, the created in the image of God, the values which we hold on gently, sensitively to others. But I would never impose my value on them. This is what I believe, so you should do this. No. They have to be convinced by God and God's Spirit working in their lives to take a decision. We hold on to our values. We look for opportunities where we can journey with them sensitively, with compassion, understanding what they are going through. And if God gives us opportunities to say that, this is what I believe, why don't you think about this? And leave it. And pray that God, they might take the right decision. But remember, when you give a decision, if they don't take it, give an alternative. If say they don't abort, what will say, will you take that child and care for it? They will say, we want to abort. You say, don't abort. They will say, what is the alternative? This happened to us in Raxol. Unmarried young girl came. We said, don't abort. The mother turned around and said, if you don't abort, she will be killed by my husband. Would you keep her in your hospital, take care of her 6 months? I'll stay with her and deliver the child and take the child off. Then I'll take care and go. Actually, our team did it. They created a room outside and did it. That was a great learning for me because our obstetrician there said, we will do it. So when you give an answer, if they don't follow, they turn around and ask, is there an alternative? Be the alternative. Find that alternative. It's not easy, but we need to take that step too. So, Eric, I personally would not impose, but I would gently journey with them and try to communicate what I believe. Rupa, Priya, anybody else can add on.
Yeah, just one line that it's not easy to give your suggestion and have a person say opposing views and yet stand with the person with grace and with the understanding that yes, you took that decision because you're not able to understand what I'm trying to tell you, and not letting the person go also. Like most of the cases, in most cases of abortions, etc., this happens. So
Yes.
you tell them that this is a choice and they take it otherwise, but they still need to be given the worth that, okay, you took it because it's a difficult journey for them also, in spite of choosing that they.
Yeah, but that is what we do with God every day anyway. God tells us something, we do something else and we walk away. And in one sense, all of us are same in that say. It is maybe in a clinical decision making, they might be doing it. We do it in our regular life. We don't do what we should be doing in our life. We walk away and God accepts us as we are. Unconditional acceptance. So if I understand that, I am unconditionally accepted by God, that journey should help us to accept others unconditionally, though their decisions may not be in line with the value systems I hold on. How do we become journey in that? That's the whole question. It's not easy. I'm not saying it's easy, but Elliot, I think end of a long day, I think it is.
Thanks a lot, Santosh. It's been great listening to you, bringing everything together and pointing in the right direction. Thank you.
Yes, thank you, each one of you, to be here and being patient listeners, like Dr. Santosh had mentioned, and all again emphasizing the fact that it is it's not mandatory, but it would be worthwhile to put in a look into the various day-to-day scenarios that you're going to face on a day-to-day basis. So whether you do it through ICDMA or whether you do it through TCB, but please do try and learn or understand bioethics on a greater level. So this platform was one I hope this platform was one encouragement for that.
Thank you, everyone, for your patient listening. And I feel though it's a hectic session, but the topics, they're really interesting. I must thank Dr. Ashita, Dr. Satish Thomas, Dr. Jamila, ma'am, and Dr. Priya, and Dr. Rupa. And finally, Santosh sir summarized it with the biblical perspective. And, that gives us the big picture and some, purpose in life. In the context of all the permutations and combinations and the legal and the ethical, the framework and all the challenges that we come across all the, days of our professional career. But in the end, humanism and, the biblical perspective, obviously, as Christians, people expect us to be more, expect us to take one step ahead, apart from when we compare others. So it's a challenge, and not only challenge, it's also a fulfilling thing to look at our life in that perspective and the context of the big picture we have. So we'll continue these sessions on bioethics in the days to come. Our initial plan is to begin with the foundations and foundational teaching, and we'll be continuing the learnings on bioethics in the days to come in collaboration with the Center for Bioethics, Dr. Rupa and team. So thank you everyone who has joined from overseas and different parts of the country. Thank you for your participation, which motivated us to think beyond, the routine. So thank you everyone. Over to Elliot.
Thank you, sir, for the closing note. And I request Heraldana to give the vote of thanks. Heraldana?
I thought it was completed, sir. It comprehensively covered everybody by name. So I must thank God for this opportunity for us to hold for almost about 6 hours together. Thank you, the TCB team led by Dr. Rupa, the EMFI team headed by Dr. Sukumar, who came around to host this session, and all the names which Dr. Sukumar mentioned, right from Dr. Ashita, Dr. Satish, Dr. Jamila, Dr. Priya, and Dr. Santosh finally. Thank you, one and all. Have a blessed night. Thank you. Bye.
1 second, I must thank Harold, Chaco, and Dr. Elliot for their, they've been at the back end and supporting and facilitating the program. Thank you, each one of you, for your contribution. Even Dr. Veda Simons from Mumbai, she is also part of the EMFI team. Thank you, everyone, and thank you, Dr. Rupa, and your team at TCB.
Thank you, EMFI, for this plan.
Yeah. Good night, friends.
Good night.
Sir, 1 minute, sir. There is a feedback form which has been posted in the chat box. So we'll post it in the WhatsApp group as well. Can we close with a word of prayer? Huh? I request Priyajan ma'am to close with a word of prayer.
Shall we bow our heads in a word of prayer? Our dear heavenly, loving, sovereign God, a God who is so powerful, but yet so personal. A God who created us, who made us in his own image. A God who loves us and who will carry us through all the hardships of life and who will be there with us in the storm. A God who made life and every breathing thing so beautiful. a God who gave us the charge to look after this beauty, this creation. Father, give us your wisdom to not fail you in any way in restoring your creation and looking after it. You've given us the privilege of being healthcare professionals. We thank you, Lord. We thank you for all those opportunities you have given to us. And we pray that we will use each of those opportunities to show how we can protect, how we can show empathy, how we can just wonder and show respect and give respect to your wonderful creation and lead them to the hope that is Christ. Thank you for EMFI and TCB and each of the staff present who have made this conference possible. For each of the resource persons and their work, Lord, we ask that you will bless it. Thank you for giving us perspectives today. But at all times, Lord, let us seek the counsel of the Holy Spirit. When we have so many challenging questions in front of us, let us take a moment to quieten our hearts and to listen to your still small voice. Thank you, Jesus, for all the foundations that have been set for the TCB. And as we take bioethics forward, give us your direction and give us your heart to serve. In Jesus, we pray for every person present here today in their work, in their workspaces, with their colleagues, with their patients, with their relatives, with everyone, Lord, with their teams. Bless them. Bring back relationships that are broken or are challenging. Give them peace and joy, Lord, in all that they do. And Father, let us always carry that privilege of serving in this area of healing, knowing fully well that it comes with the compassion that you showed when you walked this earth, and you continue to show us and teach us. Let us be the presence in a world that is suffering. In Jesus' holy and most precious name we pray. Amen.
Amen.
Okay. Thank you. Good night. Good to see you, Dr. Jamila.
Good night. Good night.
Thank you, everyone.
Nice to see you all. Listen to you all. Great. When is the next conference?
Maybe in the morning. Thank you, Rupa.
Yeah, Rupa.
Everybody digest. Dinner is.
And thank you, EMFI, for all the hard work.
Yes,
Thank you, ma'am. Thank you for your support.
Thank you. Thank you.
Thank you, Dr. Sukumar. Yeah. Thank you, Elizabeth.
Thank you, ma'am.
Harold, yeah. Good night.
Good night, everyone. Good night.